was GI bleed. There was no evidence of diarrhea, but there was GI bleed. We did all the regular IBD markers, blood test, and he has had already oral antibiotics before coming to us. And this is the colonoscopy which was there. So this is picture of sigmoid colon, and if you can see that internally transverse colon is fine. So these were the kind of ulcers which were present in the sigmoid colon. So we sent other blood markers also, we sent the histology also, that but it didn't show any evidence of abscess or inflammatory bowel disease. Again, symptomatically this child was treated. He's been with us now almost for 3 years and he's perfectly fine. So the two things which were common in these two kids was eating a lot. See, every on and off kids eat junk food, but this is the kind of kids who are eating a lot of junk food, outside food, which is not healthy and giving rise to food allergies. So these are the chemicals which are present in the maybe sauces or syrups or spreads or whatever which is there in the outside food. Preservatives, basically.
So many times mushroom actually. I think mushroom is also part of it.
So that's when we do the oral food challenge test. I'll come to that also. So when I went to diagnose food allergies in children, it's nearly going to over. So whenever you are observing persistent symptom, recognize severe reaction, consider family history and utilize diagnostic tools. It is a diagnostic challenge in India because we have a data scarcity, especially for food allergies. Except apart from celiac and milk allergies, we don't have any other data for most of the kind of food allergies if they are. There is inconsistent testing because various tests are available and we are all often confused whether IgE specific test to be used or refer to a specialist. I will quickly come to the symptoms of IgE-mediated food allergy. Very important, if a child is sitting in front of you, they may present with only single organ involvement or they may present with multiple organ involvement. So any child who's coming with a blood symptom, please look into his eyes. He might have erythema in his eyes. He may have some kind of ulcers in his tongue or oral dryness or persistent cough, chest tightness, dyspnea, wheezing. Gastrointestinal symptoms are more common with non-IgE mediated food allergy, especially nausea, abdominal pain, persistent reflux, vomiting, diarrhea. Upper respiratory symptom, persistent nasal consumption. Now it is the season is going on of cold, cough, fever. However, kids who have persistent respiratory symptoms during the non-seasonal time also look for underlying food allergies. So, because I have limited time, so I would come to important slides. So whenever you are seeing consistent symptoms consistent with IgE-mediated food allergy, obtain history of reaction. If it is severe, refer to specialist. If it is a mild reaction, then and the child has eaten food multiple times without any issues, then allow them to continue the food. If they are not able to eat the food, then test for individual foods. So basically there are various diagnostic test tools available for diagnosing food allergy. They are skin prick test, specific IgE blood test, oral food challenge and elimination diet. However, what is easily available is the IgE mediated food allergy testing. The fluorescent enzyme immunoassay method are preferred now. That is, we measure the food specific IgE levels. The advantage is it is widely available, unaffected by histamines. However, the interpretation of result is very variable. Sometimes a child comes to you in the OPD and you ask them to do a food allergy test and they will do a battery of tests for the entire 200 food stuff. And out of that, maybe child must have eaten only 40 or 30 food stuff. And sometimes it turns out to be falsely positive. So then it becomes a confusion. So just be aware of esophagitis. It is very, very common, but it is a diagnosis by endoscopy only. Usually infant and toddlers presenting with reflux symptoms or school age children or adolescent children presenting with dysphagia, please look for eosinophilic esophagitis. So these are the ulcers that you see on endoscopy. So I'll just quickly come to the treatment.
No, doctor, it's okay treatment.
Oral food challenge is the treatment, and I will stop on this slide so that you can have a read through. And if there is, any questions?
Is there any question from the audience?
So I think
But early introduction of the food is, I think, the key.
Yes. So that's why I stopped on this slide. As you rightly said, there is no evidence of delaying in the introduction of allergenic foods. So early introduction of food at around 4 to 6 months of age is now recommended.
So I did generate a need for AI into it also, where everything can, data can be given and you can come to certain time. Very nice presentation, Mr. Sulta, is for the interest of time. So we are
So I think we can proceed for participation now. Our speaker is Dr. Nishant Vardra.
I am not leaving because I know. I will ask you.
Yes.
Later.
Thank you, respected chairperson. With your permission, I would like to begin. I was given the topic of fresh blood in stools, and it's a very common occurrence in a busy OPD practice when the parents come to you with either the history or a diaper or a picture of a diaper wherein there is blood in stools, and then it's your job to make a diagnosis as early as possible, because blood in stool is a alarming symptom as much as blood in vomit is in a newborn or an infant or a toddler or an older child. So fresh blood in stools is actually, what this means is that the bleeding is below the level of ligament of Treves, and it's the amount, clinical presentation depends on the amount and the rate at which the blood is being lost. So I'll take you quickly through some case slides and then sum it up as on how we should, as pediatricians or pediatric gastroenterologists, approach such a child. So a boy, normal delivery, birth weight is good, exclusively breastfed, he is gaining weight, and the mother is now supposed to join her duties, professional duties, and that's when cow's milk is introduced, either in the form of a formula or directly. And this is the picture they send me, that in the diaper they have found some blood and mucus in stool. Now the baby is well looking, thriving well, child is happy, parents are distressed. This is the blood parameters of this child. So there are RBCs and pustules in the stool. Some stool culture was also done which showed E. coli, but we should not go by this one report because it is misleading. 9 out of 10 times, rather 10 out of 10 times. So what you're actually facing with here is for food protein induced allergic proctocolitis. Now these are mild symptoms, blood and mucus in stool. Stools are maybe normal or loose. And the onset can be within the first 6 months or even the first year of life. It is a common cause of rectal bleed, we do know, and it is also prevalent in exclusively breastfed infants. And in them, the prevalence is 1 to 2 per 1,000 exclusively breastfed infants. Second case is of a 6-month-old girl child who is developmentally normal, immunized for age, has a BCG scar, she's doing well, and then suddenly develops loose stools which are watery initially and then mucoid. And then she starts passing maroon-colored blood over the last 48 hours. There's increased irritability, and that's when they reach us. The child is thriving well, but there is a mass that is felt in the right iliac fossa, which usually clinches the diagnosis in these children. The lab parameters show anemia as well as a raised CRP, and the cultures are normal. So the diagnosis is usually clinched by an ultrasound, which confirms the diagnosis of intussusception, and we know the management of these children, which requires IV fluid, antibiotics, and a surgical procedure. Many times, the picture which comes to a pediatrician's mobile phone is looking like this. Now, there is a child who is absolutely thriving well, like this 2-year-old girl child who is developmentally normal, immunized for age, and then there is sudden passage of blood per rectum for the last 15 days, fresh blood after the passage of stools, no pain, she doesn't complain of pain at all, and there is no history of constipation, which one can actually see as well. So this particular child is as well thriving well, no organomegaly, other systems are normal, growth parameters are absolutely normal, and the lab parameters show anemia, nothing else. The INR is normal, there is no coagulopathy, and what you find on a sigmoidoscopy is a polyp. And obviously this child would benefit with a polypectomy. So polyps are painless causes of bleed in a child who is otherwise non-constipated and doing absolutely well. And most of these polyps are juvenile rectal polyps, and their chances of recurrence are pretty less. So this was the child, and a polypectomy was done post-colonoscopy. Now, while you're getting all these children with milk protein allergy, intussusception, polyps, and etc., once in a while you come across an older child. Now, these instances are also coming in younger children, like this particular case of a 12-year-old with blood and mucus in stool, tenesmus, and low-grade fever. Now, this is a very common occurrence, and usually the first history which one would ask the parents is कि आपने कहीं बाहर तो नहीं खाना खाया वगैरह. This child is thriving well, and on per abdomen examination is normal. He receives an oral course of antibiotics. The stool frequency reduces, the blood also in the stool improves, but he does not achieve complete relief, and that's when the stool is sent for investigation, which shows pus cells and RBCs fulfilled. The stool culture shows no pathogenic organism, as would have been the case had it been a case of dysentery. And C. difficile is negative, but the CRP is high. So you have a case of inflammatory proctosigmoiditis leading to tenesmus, blood in stools, and fever secondary to inflammation. And in view of persistent blood and mucus in stool, with no relief on antibiotics, this is when the child is referred for colonoscopy, and on colonoscopy we will find the whole colon is full of riddled with ulcers, there is loss of mucosal vascularity, and there can be at times abscesses as well, which were not present in this case. So right from rectum, sigmoid, descending transverse to ascending colon, you might have a case picture of pancolitis. Now, while this child has been referred for bleeding PR, we also do an upper GI endoscopy. And the reason is that there is an entity called Crohn's colitis, and we know that Crohn's disease can have ulcers even in the upper GI tract. So a normal looking upper GI endoscopy can be reassuring in helping us making a diagnosis of ulcerative colitis if the biopsy picture looks like this. So this child has active inflammation, as can be seen, and within the crypts, the inflammatory cells are increased in tremendous numbers. So this is how an ulcerative colitis histopathology looks like. So the diagnosis is ulcerative colitis. Why? Because the upper GI endoscopy and biopsy is normal. The pointers in the history and examination are: 1, the child had been having blood pain in abdomen, and then he had blood and mucus in stool. The child, while he had an acute episode, it continued to progress despite having been given 10 days of antibiotics, which would have responded had this been a case of dysentery. So in this particular child, the treatment options available are both steroids, immunomodulators, as well as anti-inflammatory, locally acting anti-inflammatory medications. And as I mentioned, there is a definitive role of upper GI endoscopy because you don't want to miss a case of Crohn's disease, which has a slightly different line of treatment nowadays as compared to ulcerative colitis. But then a very good friend of mine who had actually referred this patient to me asked for differential diagnosis, and so to complete the list, and he said that you see so many of inflammatory bowel disease, my friend, I am not going to see all of those. So give me a list of differentials which I need to look for when such a child comes to me. So these are the differentials. So you can have C. difficile diarrhea, CMV colitis, especially in an immunocompromised child. And when I say immunocompromised, it could be a child with connective tissue disorder who has been on steroid, or a child who has been following up with you for nephrotic syndrome who is on steroid. These children can also develop CMV colitis. Children can develop tuberculosis, but it would be very rare for them to present to you with blood in stools or mucus in stools. More often than not, they will have failure to thrive, low-grade fever, poor appetite, and diarrhea, on and off diarrhea, alternating with constipation. Now, immune deficiency disorders are something which we are diagnosing more than ever. So they can also present like this. And if the child is not improving, you can actually evaluate them for both CGD as well as common variable immune deficiency syndromes. Eosinophilic enterocolitis. Now, while Dr. Sufla just mentioned a case of eosinophilic gastritis, eosinophilic enterocolitis is also a known disease where you can have blood in stools. Behçet's disease as well as small vessel vasculitis can present, but these present with leaking per rectum with a lot of pain. Solitary rectal ulcer syndrome, which is a case of chronic constipation with dysynergic defecation leading to blood in stools, is another entity which is on the rise as the constipation diagnosis is on the rise. So if you have fresh blood in stools, the differentials are like this. One, if it's a newborn, then obviously three differentials need to be immediately looked into: necrotizing enterocolitis, malrotation with valvulus, as well as allergic proctosigmoiditis, like I mentioned. And of course, you won't like to miss hemorrhagic disease of the newborn. In infancy, you can still have infectious colitis or allergic proctosigmoiditis, but then intussusception, Meckel's malrotation can still present in this age group. Hirschsprung presenting with bleeding per rectum is an extremely rare phenomenon. In preschool children and in school-age children, anal fissure, infectious colitis, polyp, etc. can be the commonest problems. But if you are faced with a child, acute onset, blood in stools, fresh blood, pain abdomen, do think of phenoxyl purpura, especially if the child comes to you with an urticarial rash, because the characteristic rash of HSP may not have presented by then. And this is now pretty common in our own city, coming across children with urticarial rash with severe abdominal pain and blood in stools. So you will come across more such children. These children classically have to be treated as HSP, and the single most important test which you can get done in these children is urine routine to look for RBCs. If they are present, the chances are you're on the right track. Give them steroids, they'll improve. Meckel scan is one test which most of the kids get done before they reach me, and I just wanted to highlight here two things. One, giving them an H2 blocker to enhance uptake is very good to improve the sensitivity and specificity of the test. But in usually a Meckel diverticulum, what you're going to have is a painless bleeding per rectum in any age group child. The oldest child which I have come across was a 15-year-old. And Meckel scan will be positive on only 50% of these children. So the chances of picking up a Meckel's diverticulum on a Meckel scan is only in 50% of the individuals. This is something which we need to know, because many times you have to go for a CT to look for a diverticulum, where in a child who is having fresh blood in stools. Besides these investigations, two tests which also help us while we do sigmoid and colonoscopies is radiographic analysis, of which can be either a direct angiography where we can detect bleeding rates of 0.5 to 1 ml per minute, and we can even do a therapeutic embolizations and coiling where the child is bleeding a lot. And the other test which usually helps and is easily done is a CT angiography in a child who either has a small vasculitis or an amount of bleed which is far excess to what you could have picked up otherwise when the Meckel's has been ruled out. So what should a pediatrician do? So I thought I'll just sum it up in the last two slides. If you have a child with fresh blood in stools and it is painful, now there are only three ways in which this pain can be the manifestation along with fresh blood. Either it's gut ischemia or gut inflammation, or you have a child who has loaded gut. as we commonly see a child who is constipation. So if you have this presentation in a constipated child, please look for an anal fissure. You should be able to examine and find it and treat accordingly. If the gut is inflamed, and this is one of the other differentials, it can either, inflammation can be secondary to infection, which can be more commonly seen with acute onset dysentery, CMV colitis or C. difficile diarrhea and immunocompromised. Allergic, as in allergic proctosigmoiditis in less than 1 month old kid who has blood and mucus in stool and has recently been shifted to animal milk preparations. Or, as I mentioned, in like a 12-year-old boy who has IBD presenting as ulcerative colitis or Crohn's colitis. Now, gut ischemia results in a pain which is much more severe than both of these other pains, and these children present to ER with acute abdominal pain and fresh blood in stools. The commonest diagnosis which we as pediatricians can come across is intussusception or HSP, but there is a less common diagnosis of small vessel vasculitis, which also presents with a very severe abdominal pain and blood in stool, which can be confirmed with inflammatory markers as well as a CT angiographic study. But if you are faced with a child with fresh blood in stools which is painless, then this is the chart which should be followed. If it's an acute onset painless fresh blood in stools, and if it's large amount, it's sporadic, there is no mucus in stool and it has no relations to stools. You just see a diaper which is full of blood. There is no stool in it. Think of Meckel's diverticulum. The chances of finding Meckel's are much higher. But if you have a chronic intermittent painless bleed, which usually happens after the passage of stool in a non-constipated child, the first differential would be a rectal polyp, which is usually a juvenile rectal polyp requiring a colonoscopy to make a diagnosis. And these rectal polyps can sometimes, in 20% cases, have additional polyps in the sigmoid colon, so one has to look up to the splenic picture. While we are looking for polyps in these children, we do come across children who have had vascular malformations. And these vascular malformations are very rare, but if they are present, they can be easily tackled. So, to sum up, the key messages from my talk would be the type of bleed, the extent of bleed, and the clinical condition is important in making a diagnosis as well as the management protocol for a particular child. Age is an important clue to diagnosis. We do now have children who have very early onset IBD. So children who we earlier thought of milk protein allergy can now be diagnosed as IBD, but it is, as you know, rare. And 99% of the bleeds can be controlled effectively, and the children can have 100% results. Thank you so much.
In 0 to 1 month of age, you had mentioned allergic proctocolitis. Allergic due to what?
Milk protein allergy, animal milk protein allergy. Can be due to IBD, it can be due to infection, it can be due to allergy. And the commonest allergen in the first year of life or even first month of life is animal milk protein allergy, bovine milk protein allergy, or cow, buffalo's goat milk. So that can happen with your normal formulas as well because they are all derived from animals.
And how common is Meckel's diverticulum in India as a cause?
It is quite common, but most of these are not diagnosed by pediatricians, they are diagnosed by pediatric surgeons, and that is why we feel that it is less common. But yes, Meckel's diverticulum is quite common. Meckel's diverticulum as such is quite common as anatomically, but when will they actually bleed and at what age depends on several factors, and these are very unknown factors. It could be a viral infection, but usually the bleed is torrential. It is not associated with stools. You are having bleeding pattern. There is no relation to passage of stool, and there is no mucus. The amount of blood is huge, and usually by the time they reach me, they have a hemoglobin of 4 or 5 or 6, and they have probably even have a PRBC transfusion.
So when a baby comes to us in the OPD mostly within 0 to 3 months after delivery, and there is a diaper full of blood or a few specks of blood, they are so anxious, the parents. So what would be the baseline investigation as a pediatrician in OPD basis?
Yeah, so the first case which I mentioned, this is the kind of diaper they will come up to you with. There is mucus, there is blood, and so essentially if the child, and there are certain pointers towards the diagnosis. If the child has been...
ऐसे रहेंगे जिसकी 5 साल की
this case from the age group 4 to 60, and we have done the rationalization 2:1, 2 being the vaccine arm and 1 being the placebo arm, wherein we have incorporated both the subjects. 72% of them were seropositive and 28% were seronegative, and that was one of the guidelines laid down by the WHO that at least 20% of them should be seronegative. That was the learning from the previous vaccine, because that was giving the side effects in the seronegative participants. So they wanted at least 20% seronegative subjects. So we checkmarked that thing by opting 28%. We run this trial for 4.5 years with the active febrile illness surveillance we conducted throughout the trial. This was a 2-dose, 0 month and 3-month regime, and we did the subcutaneous 0.5 ml dose. After 12 months, we checked the primary endpoint, which was vaccine efficacy against virulent confirmed dengue cases, and after 18 months, we evaluated the secondary endpoint, which was against hospitalization. We also did 4.5-year exploratory endpoints. Throughout the trials, we run the active febrile illness surveillance, as I mentioned previously. But taking you to the overall efficacy and the primary and secondary endpoint efficacy of TAC-003, if I can ask Dr. Pankaj Goyal sir to throw light on this topic.
So, whenever we talk of the vaccine efficacy, like it should be at least in the terms of short-term efficacy, long-term efficacy, then it should be in this particular vaccine working both in seropositive and seronegative individuals at the baseline or the starting point. And fourth is the efficacy should be there against all the serotypes. So all the things are important. So talking of the short-term efficacy, it was seen that the primary endpoint efficacy of the vaccine against the virologically confirmed dengue was 80.2%. So this is against our normal dengue fever, as we are talking about. This is 12 months after the vaccination. And 18 months after the vaccination, when secondary endpoint was seen, this is the thing that we are interested in, that is severe dengue or reduction in hospitalization, that was found out to be 90.4%. So which is a very, very promising figure. So practically we are talking that 90.4% would be prevented from hospitalization, which actually would have got hospitalized in the control arm. So this is the short term. Secondly, when we went on to see the data after 4.5 years, it was seen that the overall efficacy had come down to 61.2, but still it is very good, and this we are talking of dengue fever. Secondly, in seronegative group, it was 53.5, and in the seropositive group at the baseline, it was nearly 65%. So this is at the end of 4.5 years after vaccination, which is quite a promising figure. And if we see the same condition in the hospitalized patients, that is severe dengue, so these are the magical numbers. We can see still the overall efficacy is around 85%. In the seronegative group, which was at the baseline, it is around 80%, but a wonderful figure of 86% against which was seropositive group. This is the prevention of hospitalization or severe dengue, and this is the thing actually which we are worried about. It is like कोरोना हो जाए कोई बात नहीं, सीवियर नहीं होना चाहिए. Similar is the case here. डेंगू हो जाए कोई बात नहीं, सीवियर नहीं होना चाहिए. तो dengue, severe dengue से protection efficacy was 86% at the end of 4.5 years in seropositive baseline group, and seronegative baseline group it was 80%. Coming to the third part, that is talking about all the serotypes, because it has to be against all the serotypes. That is very, very important. It was found that the vaccine works best against dengue 2. That is the most prevalent in our country and across the globe also. Seconded by dengue 1. So dengue 2 and 1 are the beautifully covered serotypes by the vaccine. The vaccine efficacy falls down to 40s, reaching up to 50s regarding 3 and 4. So the efficacy against 3 and 4 is also good, but it has been historically seen that you are not having lot of 3 and 4 cases across the globe, even if you see the 70-year data. So the studies are ongoing for dengue 3 and 4 also, but as of now, at the end of 4.5 years, the efficacy is still around 50% for 3 and 4, best for dengue 2, followed by dengue 1. So a good data, and the studies are going on for 3 and 4. Talking of seropositive, the vaccine works well for all the 4 serotypes. In seronegative baseline individuals, 3 and 4 data is still to be presented as the number of candidates were less. Thank you.
Thank you, sir. As you rightly mentioned that there were less subject numbers for 23 and 24. That said, we are actually conducting another trial wherein we have already launched this vaccine, countries like Thailand, Malaysia. And we'll be taking 70,000 subjects in that, and we'll be a 3-year trial where we'll be focusing towards 23 and 24 seronegative participants. Also, if I take you through the Kaplan-Meier curve over here, you can see there's an early and sustained separation observed between the placebo arm and the TAC003 arm. So dotted line over here is the TAC003, representing black one is the seronegative and seropositive red one. And similarly, the solid line over here, black, is the seronegative placebo and seropositive placebo. So you can see the sustained separation. The early separation was observed between these two arms, and also the graph was not dipping down even after the 4.5 years. So we were able to get and generate the balanced immune response against all the 4 serotypes. Now, coming to the very important aspects.
Positive. So the baseline seronegative and positive behave similarly, and the side effects or the chances of developing a severe infection, severe disease later on are lesser than even placebo arm. So there was no increase in the severity of dengue seen in those who were seronegative and got the vaccine. The local side effects which we see in most vaccines are similar to most vaccines, just the similar pain, fever, mild pruritus, mild rash, which we see with most live attenuated vaccine, not very significant. Again, similar to the placebo, so very well tolerated vaccine, which and it can be co-administered with other vaccines where it's been tried, and hepatitis A and HPV are ones which we commonly use. Yellow fever vaccine obviously we don't use that much, but the tolerability of the vaccine and the co-administration was favorable.
So yeah, as mentioned, so we were not able to see any of the severe adverse events with the TAC003 over the 4.5-year trial that we ran, and also since this vaccine is launched first in 2022 in August, and it's almost more than 3 years now, and we have not observed any of the severe adverse events coming from the real world data set as well. Now coming to the dosage and indication, if I may ask Dr. Vipul Jain sir to discuss about this. So what is the rationale why we have opted for 2 doses in TAC003?
Dosage is simple. Actually, single dose of this vaccine gives immunity to almost 85% cases for all 4 valencies. And if you give the second dose after 3 months of the first dose, you cover 99.5% cases with all 4 serotypes. And it is indicated for all children above 4 years and adults. Use is subcutaneous. Being a live vaccine like chickenpox vaccine, it has to be given subcutaneous, which is very important. It is not intramuscular vaccine, it is a subcutaneous vaccine. It comes in a lyophilized vaccine, as a lyophilized vaccine as the chickenpox vaccine, and hypersensitivity is as usual with that, with the constituents and things like that, and should not be given. Being a live vaccine, should not be given to immunocompromised children having HIV or any other immunocompromised condition to not yet being studied in pregnant women and breastfeeding women. And the precautions of the live vaccines, it has to be separated by 4 weeks with any other live vaccine if not given together, but 2 live vaccines can be given together. I think that's...
Yeah. So, and as Sir rightly mentioned, we opted for 2 doses. We actually tried dose apart like 2 months, 3 months and 6 months. We were able to achieve an improved seroconversion in the shorter period of time when we opted for 3 months. So that was the reason for opting 0 months and 3 months in this case. And again, the seroconversion increased from 85% to 99.5% upon the second dose. And I'll take you through the last segment over here, where we'll talk about the worldwide regulatory status of TAC 003, where exactly it's been launched, what is the approval status, where we are standing as of now in 2025. So in August 2022, Indonesia approved this vaccine from the age group of 4 to 60. Then in 2022, we got the approval from EU from the age group above 4. And in 2023, UK, Thailand, Argentina approved this vaccine for the age group of 4 and above. And in 24, Brazil, Colombia opted for this vaccine from 4 to 60 years of age. Importantly, in 2024, the vaccine got approved in Malaysia, Vietnam, Israel, Switzerland. And plus, most importantly, it got within the 9 months of the approval, it got recognized by the National Immunization Program of Brazil, and it was incorporated in the NIP program of Brazil. And also, it was a part of the state immunization program of Argentina. And similarly, Indonesia has also started rolling out in their state immunization program. They've got the WHO position paper in 2024, and also it is a WHO pre-qualified vaccine, which got approval status in 2024. Just to give you a snapshot about the large-scale utilization of the TAC 003, the real-world experience of the endemic countries, the main 2 countries, Brazil and Argentina, those who have opted for the National Immunization Program, State Immunization Program respectively. So in Brazil, as I mentioned, it was included in the NIP end of 2023. The target age group initially was 10 to 11, but then they increased from 10 to 14, and this is the age cohort which was recognized as a severe disease in their region. And they focused rollout in 16 states with the high daily transmission of dengue predominance. Whereas in Argentina, it was through the decentralized program in 2024, Ministry of Health targets 15 to 39 years of age group. And the doses was given in 11 provinces across by the Ministry of Health of Argentina. And we did the surveillance, we found the low incidence of the adverse event recorded in both Brazil and Argentina, and more than 11 million doses was given in Brazil itself. And just to summarize everything in one page, it is TAC 003 is the live attenuated tetravalent dengue vaccine with dengue as a genetic backbone, where we have engineered and substituted PRM and E proteins of dengue1, dengue3, and dengue4. We've completed a robust clinical trial development program, and still the program is going on in non-endemic countries, where we have run 20 clinical trials over 28 subjects, and we have achieved long-term efficacy and safety profile of 4.5 years, and with an efficacy, vaccine efficacy against the BCG was found to be 61.2% after 4.5 years, and against hospitalization, as I mentioned, was quite important. It was found to be 84.1%. We got the positive CHMP opinion with EMA approval and approved in 40 different countries from the age group of 4 and above. We received the WHO Sales Committee recommendation in 2024, and it is now in the WHO pre-qualified vaccine. It's already been included in the NLP program Brazil, as I mentioned, and in India, everyone is waiting. So the India launch, we are hopeful that it will be there in the next mid-year. It's under review right now with the DCGI. So that's all from our end. Thank you so much. If you have any questions, we'll be happy to answer.
Thank you, Dr. Ankit. I think you can proceed for the felicitation. We are already short of time.
One thing I want to ask, age-related differences in immunogenicity and efficacy, because it started from 4 years to 60 years, age-related differences.
So we are not...
Also an immunogenicity.
Yes.
स्लाइड्स बहुत ज़्यादा हो रही थी, so we removed that. There was immunogenicity का चार्ट था इस पे for different age groups, and it's very similar.
सर एज का भी डिफरेंस नहीं है और प्रीवियस इन्फेक्शन का भी डिफरेंस नहीं है इम्यूनोजेनिसिटी पे.
So thank you, Dr. Thank you, our esteemed panelists, Dr. Vipul, Dr. Gaurav, Dr. Pankaj. And I think we wait and watch in a watchful anticipation for a very much needed vaccine.
It is heartening to note that it is effective equally for seronegative and seropositive, unlike the previous vaccine, and it carries great burden. So we are eagerly waiting and hopeful with so much real-world effectiveness data, it should be available soon.
And
So we will
very
be
importantly,
having meetings also for the extending this disease.
yes, very importantly, we won't have to counsel the patient to take this vaccine. Every patient will be more than eager to get dengue vaccine because everyone has seen how difficult this disease is.
Thank you.
Thank you, panelists. I think you can.
Oh, it turned out to be me only. Thank you.
Dr. Princey.
Yeah, come. Dr. Princey is the second winner.
Dr. Gopal Sharma.
Dr. Gopal Sharma, please. नहीं है
मैंने देखा रंजीन नंदा, अरे तालियां बजाइए, सबको इनाम मिल रहा है।
Ranjit Nanda. Yeah. Please come. So this one is Dr. Anju Agarwal. Is she here? Yeah, she is there. एंड में मिलेंगे ये, so please keep them safe.
Begin your session.
Briefly to the management of childhood otitis media, I think it is one of the commonest and pediatric problem we encounter across ARI and diarrhea, and this is the third common thing we commonly see. So before that, I think let me introduce my chairperson, Dr. Bajaj, who is the president of IAP. The first time the IAP went into it was hot, and Dr. J. Sethi is my good friend, pediatrician from Westcon. And now we can start the session. So this childhood otitis media is one of the common things we see often in our pediatric practice. The important thing is the treatment part, which clinicians should know, because once we treat it, we confirm otitis media, and then we definitely are going to prevent all the complications of otitis media. This is a brief child, 2 years old, who presents with fever, pain in ear, history of clear discharge. No history of clear discharge. Mother says the child had mild cold, sore throat, and she was given antibiotic, amoxicillin, and patient was treated by a pediatrician. And mother informed that after 3 days, child continues to have a fever and ear pain and become more irritable. It means the child has not responded. So what to do about that? So can somebody guess what could be the wrong thing here? Child has not responded to antibiotic treatment. Child has been given amoxicillin, child has not responded. Just basic thing, child may not have taken treatment properly, the dosage would have been inadequate, or it could have been a wrong diagnosis. So anything is possible. But clinically you see this child has got otitis media itself because the symptoms are swelling. Or antibiotic is not working, antibiotic resistance. This is one of the commonest things we are getting nowadays. And on examination reveals the febrile child and normal pulse and essential vitals being normal, but on this ear examination there was a bulge in tympanic membrane, which is the hallmark sign of otitis media, acute otitis media. It was red also and cloudy, and the left tympanic membrane. So definitely it was a otitis media. Now we'll go to the brief discussion on otitis media. We'll come to the treatment part in the end, why this child has not responded. And acute otitis media is the commonest thing we get in 6 to 24 months. Pain, fever, and on examination of tympanic membrane, the definite bulge and erythema is there. Remember, the bulge is very, very important in a diagnosis because the erythema may be normal when the child cries. You will find slight redness in the tympanic membrane. And apart from that, there can be a limited mobility. And of course, if there is a purulent ear discharge, it is clear cut. If it is not due to otitis externitis, it is because of media only. And pneumatic otoscopy is the gold standard, which I think we should basically, as a pediatrician, we should have an otoscope to detect otitis media and see the ear examination. And otitis media with effusion is the second identity, which is the spectrum of otitis media. And the features are almost the same, in which this is basically a spectrum of otitis media. There is a fluid in the middle ear cavity, and if the signs of acute inflammations are present, it suggests acute otitis media. And again, it is diagnosed by the ear examination doing the otoscope. And treatment part I will come to the next slides. And what is persistent otitis media? There is no improvement after 48 to 72 hours in acute otitis media. And recurrent is when we get more than 3 episodes in a 6 month period. And in a year we get 4 episodes, and the last episode in the last 6 months. So this is the basic definitions of recurrent and otitis media. This definition has been made so that management becomes easy. What kind of antibiotics we want to choose, it will depend on whether we know it is persistent or recurrent. And this is the overall statement, because these are the 3 main organisms which are responsible for otitis. We all know about it: strep pneumoniae, non-typable H.phalangia, and Moxella catarrhalis. And amongst the most common is the strep pneumoniae, which is carrying resistance nowadays. That's why the management of otitis media become very, very important. And the common stereotypes which are responsible for otitis media are 11A, 19F, and 15B. And this is the spectrum presentation of otitis media. Majority of them will present with chronic otitis media, suppurative otitis media. Now, how to manage AOM? Now, this was a group which was formed by pediatricians and physicians. They decided to have aggravated by this, these are the predisposing factors for otitis media. I will not go into the detail because it will become, time is very short. Basically, it is all related to feeding processes, overcrowding, daycare center, bottle feeding, and same is the risk factor for otitis media with effusion. Both are the spectrum of the otitis media, AOM as well as OME. Now, the important thing they have been described is that the concentration of the antibiotics should be around 40 to 50% of the drug concentration above the middle ear, in the middle ear, who is responsible to take care of the otitis media treatment part. Now, what is the management of AOM? The basic thing, these are the various groups in which have been divided. So, the first is whether we should treat a child with otitis media or start with an antibiotic. This is the main thing, and it was found that the children about 2 years who don't have a very severe OM, they can be, if they are available for follow-up, they have a low-grade fever, duration of the fever is less than, or pain is less than 48 hours, they can, if they are coming up for follow-up, you can wait the child and then you can confirm the diagnosis later on after 48 hours. Because majority of the otitis media above 2 years, they respond, they basically get cured themselves. And whenever, second possibility, you can hold the antibiotic is between the 6 and 2 years, wherever you can just have a doubtful diagnosis of the otitis media. Now finally, I will just skip few slides. Treatment is again, treatment of the symptoms. Basically, you can give paracetamol or analgesic for the ear pain. No local ear drop should be given in any treatment of otitis media. And now coming on to the antibiotic part, which is the most important. Now 6 months to 2 years, remember that child with confirmed otitis media, you have to treat with antibiotics. And about 2 years, if it is a non-severe AOM, you can wait for the child to come up for follow-up. And if it is about 2 years and there is a severe disease, you can start the antibiotic. Remember, the 6 months to 2 years and below 6 months, the antibiotic has to be given, provided this is a confirmed hepatitis media. Above 2 years, if the symptoms are not severe, you can always call the child later on after 48 hours and you can start the antibiotics. If it is a confirmed case, always give antibiotic whether it is above 2 years or 2 years, below 2 years or above 2 years. But if it is above 2 years with severe symptoms, you can always start the antibiotic. Remember this. Severe means the child is febrile, toxic, very severe pain. You cannot hold the antibiotic, you have to give it. And this is the basically treatment chart. So initial treatment according to this Delphi study was that you start with a standard treatment of amoxicillin 40 milligram per kg, and if the child does not respond within 72 hours, then you increase the dose of amoxicillin, you start amoxiclav, and that dose is in the range of 80 to 90 milligram per kg. And remember, this treatment has to be given for 10 days, and there are few exceptions for that. Sometimes the child has got a very severe disease, you can straight away start amoxiclav like this thing, the second line there. So, and now, see, this is the only thing which is controversial in the second part. The children with severe disease. Children with severe disease, better was, there was a group which was saying that you should go with the standard dose, amoxicillin 40 milligram. Then another group which was divided and said the severe disease, we have to give antibiotic in a higher dose, so that's why the amoxiclav was recommended. And any child with conjunctivitis, associated with otitis media, it is because of the non-typable H. influenzae, and you always give amoxiclav. There is no chance of giving amoxicillin. And third thing is, if there is a no response even after to amoxicillin clavulanic acid, you can go for ceftriaxone therapy, 50 milligram per kg for 3 days. So these were the basically consensus group formed by the Delphi group. Now another thing is, if the child is allergic to penicillin, what are the choices we have? Then we have the choices of ceftriaxone, cipraloxime and ceftriaxone. Now again, these are the dosages, and this is only in cases of the penicillin sensitive individuals. Among them, the most effective is ceftriaxone. Now recurrent otitis media, if there is a persistence of recurrent otitis within 1 month, or the child has received amoxicillin due to otitis media, you straight away start with the amoxiclavic acid. And lastly, these are the surgical management. Basically, if the child has not responded to your treatment of otitis media, you should always follow it up with the otolaryngology ENT people to find out what are the reasons. You have given the amoxicillin, amoxiclav, and the treatment has failed. You always take the opinion of the ENT surgeon. Basically, there could be other anatomical or surgical interventions which will be required. And lastly, these are antibiotics basically which are not that effective. These are the secondary choices. Azithromycin is the most resistant one. Erythromycin and clindamycin are often being used in penicillin sensitive individuals. I think I will close it here. This is in relation to otitis media only. Rest all is not a part of this thing. This is in related to the otitis media with confusion.
I think this is an open and shut, I think very precise and quick presentation, I think which covers most of the things. I just want to have one poll. How many of us are using otoscope? So I think still more people
but
are
not pneumatic. No, not pneumatic.
No, that's not
Silver. That is not golden.
I think we don't need. Our basic job is we have to. If it is suppurative otitis media, we will give antibiotics. Problem comes with is non-suppurative otitis media, or we are not able to diagnose below 6 months. So there comes it. Below 6 months, it is very difficult to examine tympanic membrane. But clinically, we sometimes start. It's better to give.
I think most of us should have, all of us should have otoscope as a thing to look at it. And how many people they have with high dose amoxicillin and diarrhea? Is it
diarrhea in infant is little more common as compared to the older age, but it subsides with probability.
Diarrhea does not occur generally because of amoxicillin, it occurs basically because of clavulanic. So if you are giving less dose of clavulanic,
diarrhea happens with amoxiclav, but it is treatable.
It's not a big problem.
Treatment of otitis media itself is
Any question if somebody
that
has?
can be done outside. Are we already behind the schedule?
Thank you so much.
Thank you so much, Dr.
Thank you,
Lalit.
the chairpersons.
thank you the audience for listening. I think
Yeah.
thank you very much. I think we should always appreciate the audience sitting after lunch. Thank you very much, the audience.
Absolutely.
I really clap for the audience here being present here.
Yeah. As we move on to the next session, Dr. Lalit Mehta, may I request you to please continue sitting as you are a chairperson. Now, welcome Dr. Neeta. There are other chairpersons as well. Dr. Kiran Shankar Banerjee. Yeah. Sorry,
workers, everybody should be aware about this because it is a very, very burning problem which is engulfing our youth, and we pediatricians have the responsibility to spread the awareness about substance abuse in adolescents. So, to introduce substance use, abuse or disorder, everything is on the rise. Worldwide, this is the third largest business after oil and arms. So just imagine how many people are pushing this crime into the world for the huge profit. It's a $400 billion business. According to the report of United Nations on Drugs and Crime, in 2025 they have reported more than 300 million users of drug, and 64 million out of those are substance abuse disorder. So the problem is huge, and this starts most of the time, 70% of the time, the drug abuse starts in teens, and we have a huge teen population, 22.8%, and only 1 in 11 is getting the treatment of this substance use disorder. That means it is not that 1 in 11 is wanting the treatment, but the treatment is not accessible, it is not low cost, there is a lot of stigma with this, and Delhi is becoming the hot spot. Just because we don't see it, because we are ignoring it, but it is there, it has reached our neighborhood, it has reached the school bags of our students. And inhalation mode is the most common in children. Why? I would tell you. So this is the report of the United Nations on Drugs and Crime, which I have already mentioned. So every year 26 June is celebrated as the Drug Day. In 2024 only they had kept the theme as evidence is clear, invest in prevention. So we don't need to know that it is not there, it is very much there. We just need to invest in prevention and treatment and support. 2025 theme is break the cycle, stop organized crime, because it's an organized crime all over the globe, and we must break the cycle. The government must take action, and this theme also emphasizes on more therapeutic and supportive measures than the punitive measures. So we should decriminalize substance use. So what is substance use? Anything, use of drugs, medicine, any substance beyond the intended use which has the potential of addiction and harm, be it physical or psychological. Why adolescent? We know that adolescents have a complex interaction of biological, genetic, they are developing puberty, testosterone, environmental, peer group. So everything plays a complex interaction, and they are more prone to use this. How it starts? Nobody starts as an addiction. Every child, they start as an adventure, as a pleasure from the peer, out of curiosity, but when it turns to addiction, nobody knows. The environment, the media influence, the media is glamorizing it. People are posting pictures with the hookah, and they are vaping and they are drinking, so it's being glamorized and children are being affected. Lack of guidance, lack of coping skill, they don't have anybody to turn to. We are not receptive that when they come and talk to us about drug, we will be able to discuss it without judgment. So these are the root cause: family factors, broken homes, emotional abuse, lack of supervision, individual factors, low self-esteem, career pressure is there. Now, after class 9, 10, we want students to just study and clear those entrance examinations, and they leave all their sports, all their hobbies which they were doing earlier, and they are shut in a room with the device. So the boredom, out of boredom they do it. Peer pressure is there, school stress is there, community and environment, lack of education, safety and security issues, easy availability of access of the substance. So they do it to feel good, to feel better, to do better, to explore. What is addiction? Addiction is when there is compulsive seeking of a substance or performing an activity despite negative or harmful consequences. So they are trapped. They try, they regularly use, they abuse, and then they become psychologically dependent on the drug. So why the adolescent is addicted? Because 3 areas of brain, we know that prefrontal cortex and amygdala. Amygdala is more active, prefrontal cortex is less active. So they have less decision making. They are more, they're more emotional, and impulse is more in them. So I will not talk about this. They crave intensely. They can't control. I will not. These are the modes. So common substances: illicit and licit. Tobacco, alcohol, vape, cigarettes. They are easily available. They are easily available in pawn shops, eateries. Everywhere around us, and some illicit drugs are there like cannabis, cocaine, heroin. Cannabis is very widely used around the globe. Then there are date rape drugs. So these are drugs, I will not discuss about it. They can procure it from anywhere. They can procure it from just around the school. It's mushrooming. There are parties. There are rape parties. Via the dark web. They don't have to meet the drug peddlers. They can get it through online, portals. We should be aware about these symbols, the blue diamond for meth, the cocaine, the maple leaf for because they are doing it through the media, they are doing it through networking sites. So these symbols we should be aware as a pediatrician, and we should disseminate. These are vapes, very, very fancy devices. When they do it, there is no color, there is no order, there is no nothing. There are 6,000 puffs in one vape, and they can take around 200. They finish one vape in 1 week. So they are doing 1,000 puffs in a day. So the amount is so much. I just perplexity ko maine pucha, how should I upgrade as an Indian mother to safeguard my child? So they said communicate, and come to know about the drug slang. You should be knowing about the drug slang which the adolescent is using, so that you can you understand what they are doing. This also I am not talking tolerance. So this is the DSM-5 criteria. So mild, moderate, and severe. 2 to 3, 4 to 5. These are failure to fulfill responsibilities. These are the criteria for addiction, substance abuse disorder. So they have decriminalized the legal thing. They have taken out from this, and these are the symptoms that failure to fulfill responsibilities, use in hazardous situation, there are legal issues, there are social problems. They use more than what they intend to do. They can't cut down, So, for us, what we should know about the red flag signs, so that we can spot and we can stop. So, mood swings, important. Though most of these things are problem of, many disorders in adolescents. They present like this: loss of interest in usual activities, new set of friends, they avoid social gatherings. They are secretive, they hide their personal belongings, they keep themselves locked in the room, they spend extra personal space, more in the bathroom, unexplained expenses, loss of money from home, poor personal hygiene. You might get smell and stain, you might get marks, you might get rolled papers in their room, loss of appetite, fatigue, drowsy, red eyes, injection marks. So these are red flags. If you see your child has changed a little, he's being more secretive, more aloof, he's not taking participation in the activities which he used to enjoy, your antenna should be alert, so that you see that with what problem he is going through. It's not just drug, it's so many other problems also. So adverse effects, we know that it impacts cognition, memory, emotions, learning, judgment, everything. Mental health issues are there. There are diseases, there are health, cardiac effects, headaches, injuries, accidents, legal implications. They are driving cars, they are driving under the effect of substance, so there are more chances of accidents. What is our goal? Our goal is we gather knowledge that it is there, we understand the problem, we understand the current scenario, we understand that it is there, and we understand the language also. Recognize the red flag signs. History taking heads, I will not discuss heads, but whenever the adolescent comes to our clinic, we should put a little light on the head screening, so that we can at least look into, explore their world, and we can find out if there is some area which we should, really look into. So drugs always have a third party approach that does your friend does it, have you ever seen it, do you want to do it, so that they can open up to you. Do not be a parent, do not be a friend. A non-judgmental approach is a must. Maintain confidentiality. There are some screening tools. So when you do the screening tools, if you find there is mild user or he might use, then you can do some brief intervention about counseling, and then you can refer to the counselor or the psychiatrist. Judicially treat them as victims, not as culprits. This is very, very important. This is the reason that they don't come out to us, they don't come out to authorities also. Decriminalize. It's very important. Yeah. So acknowledge, take help, support. Most important is to develop resilience. Not only saying no, but yes to many things. Family time, hobbies, exercise, setting goals. Treatment of intoxication withdrawal. This is by the psychiatrist. The healthcare system should be easily accessible, low cost, trained personnel, not stigmatized. This I am not telling again. Helpline numbers are there. The Nasha Mukta Bharat Abhiyan is very much active. They get numbers of calls. Take home message: know the current scenario of substance abuse, gather knowledge to create awareness, recognize the red flag sign, be compassionate, non-judgmental, extend support, create healthier means of dopamine reward. Take help. Thank you.
I think it is a very vast topic, and we'll just briefly summarize how you should recognize substance abuse in an adolescent when it comes to your office practice, and what all you can do about it. So, any questions somebody wants to know about in relation to substance abuse, or somebody wants to share any experience in the pediatric office and recently came.
I think apart from this, you will have to break the supply chain.
Yes,
supply is most important, and you will have to identify it.
It's a big topic.
So no question. Thank you because of time constraint. I think thank you, Dr. Nita.
Thank you.
Thank you, Dr. Nita. Thank you, our chairpersons. Please proceed to the.
So my topic is basically early intervention in craniofacial disorders. So what happens is a lot of times the problem is that parents are not able to diagnose, and pediatricians also sometimes lack the exact timing where we should be treating the child. So what defines early? It's basically not a newborn or a 3-year-old or 5-year-old guy. It depends upon the dentition, status of jaw, growth spurt, nature of malocclusion, and systemic disorder. If there is a systemic disorder by birth, the treatment totally changes. I mean, you say in cases of cleft lip palate, Pierre object sequence, tetracholis syndrome, that is totally different. I'll talk about both. Any congenital deformities or systemic disorders which are since birth, that is one part. Second part will be basic problems which are seen in day-to-day practice, which are also missed by pediatricians. There are a lot of times. So why early? Because of course we can preserve the integrity of the health of the dentition and the jaw. Then we can prevent and intercept the environmental influence from habits, abnormal muscle functions, and occlusal prematurities. Occlusal prematurity is basically the maxillomandibular relationship. Then use of growth. We actually use growth of the child to mold its muscles and bones so that we can get a more stable structure. So first part is 0 to 3 years, in which it is basically patient and parent education about feeding and pacifiers. Second is caries control and care of deciduous dentition, that is the primary dentition. And third is space maintenance. It's nothing but just making spaces for the permanent teeth to run. So patient education, basic difference between breastfeeding and bottle feeding, I think a lot of you are way more educated than me. But of course, breastfeeding is much better. For oral point of view, it stimulates the muscle around the mouth and for the normal growth, allows the gravity to work in correction of the muscles. Second comes is pacifiers. They should not be encouraged as a orthodontic point of view, because what it causes is it causes increased risk of caries, then malocclusion and ear and GIT infection, as told by Dr. Ali previously. So what happens is if you put a pacifier a very long time, the child will develop such kind of malocclusion. It causes a lot of trouble later on because this causes tongue thrusting, slurring of speech, and becomes very difficult for anybody to treat. So this opening of the mouth, later what causes is the tongue comes out. The child is not able to talk when he or she is 7 or 8 years old. So it's better that we start avoiding pacifier in practice. I mean, again, the effect of conventional orthodontic pacifiers in dental occlusion. It's higher in cases where pacifiers are given. Now comes the second part, which I told you, that is the craniofacial disorder. Some of the commons are PA of the sequence, Collins syndrome, hemifacial microsomia. It's a very long list. I will be only covering about the craniofacial part, which I deal with. It's more or less all of them have somewhere cleft which is there in the baby. So there are three parts which I deal with: is pre-surgical orthopedics, that is from 0 to 1 month. Then orthodontics, that is 10 to 15 years, and then orthognathic surgery, that is more than 18 years. So this is the normal structure, when a baby with cleft is born. We have a very big cleft, so what we do is we reduce the displacement of the alveolar segment. You can see two segments here, that is the left and the right, for explanatory thing. Then we create a butt joint between the alveolar segments in the cleft region. So what we do is the main idea is to create a normal arch form by actively molding the alveolar segments using a series of plates and apply forces to shape the nasal cartilage and restore the normal anatomical relationship of the cleft skeleton and cartilaginous soft tissue elements. Yeah, so this is what the patient comes with, and after giving the plate, the patient looks something like this. So at day 0, day 1, day 10, when the child is born like this, we give a plate which looks like this. So this plate is actually really important. It causes nasoalveolar molding. So what happens is the two alveolar segments come close to each other. So now, there is a saying that what if we directly operate on this? Some surgeons, some plastic surgeons are able to actually operate without giving the plate. The problem that comes is later on the scar tissue is bigger. Secondly, over there the dentition does not develop. First, success rate is also less if you operate like this, but that is a surgeon's perspective. For an orthodontist perspective, is the dental development of primary as well as permanent dentition is very difficult if you straight away operate like this. So if you operate like that, it's a more harmonious facial structure of a child when he or she becomes an adolescent. So another one aspect, if you are not able to get in touch with anybody who can deliver a plate, is called as a Diner clip. It is basically a tape which gets two parts together and elevates the nose. So nasal elevation is also very important, because more or lessly all the surgeons try to get the alveolus together when they are operating the cleft and they forget about the nose. When the child becomes around 10 to 11, the overall facial structure of the child is not good and he or she does not feel very confident about his or her looks. So just taking out 1 to 2 weeks when the child is just born, it makes a very big change when the child is 13 to 14, because we can use the normal structures and just giving a tape or maybe a small plate. It can be a very beneficial aspect for the child in total. Now we come to the second aspect, that is from 3 years to 7 years. One of the most common thing is thumb sucking and digit sucking. It is basically a placement of digit at various depths of the mouth. Very common, you might have been also hearing from parents that mera bachcha to anguta chota nahi hai. What happens is the teeth become like this. There is severe proclination, there is severe open bites, and there is constriction of maxillary arch. So what causes is starts a series of events. So when there is severe constriction of maxilla, breathing also becomes a problem. So you might not ask the patient that is there a problem in breathing, but constricted maxilla and incisor proclination actually causes decrease in the posterior space, and which causes difficulty in breathing on the child. Again, incisor proclination and inflammation. We can give some appliances such as thumb sucking plates. All these can be given very easily. Now there is a cycle in which thumb sucking, which causes loss of musculature, which causes proclination of upper incisor, lips become incompetent, which loses, there is a loss of lip seal and causes tongue thrust. Now tongue thrust causes open bite, which causes enlarged adenoids and causes mouth bleeding. All three habits actually are really interconnected. So it's not that one habit can be cured. Either of the three will lead to all the three. So we have to stop all the habits. Again, tongue thrusting, forward movement of the tongue tip between the teeth to meet the lower tip during deglutition. This is what happens is the vertical overlap and the horizontal overlap. So the horizontal overlap increases in a child. In this picture you can appreciate. Now the last aspect is 7 to 11 years of age. Basically, skeletal malrelation is change in shape, size, and relative position of the upper and the lower jaws. Now, there are two types of jaws which are developed, that is either class 2 or class 3. Class 2 is basically when there is a large size of maxilla, and class 3 when the mandible is big or the maxilla is backwardly placed. So, this is one of the class 2 cases. When you see a child which has protruded teeth, he or she requires immediate attention. I mean, immediate means immediate. If you do not treat the child here, he or she might need orthognathic corrections. This is what the patient will look like, and this will be the intraoral picture. If in case you are not able to ask about the intraoral picture or do not want to inspect the oral cavity, you can just see by the facial appearance of the child. Again, another picture. The maxilla will be protruding out of the jaw. It is just we have to see and refer. That's it. What we use is something called as a myofunctional appliances, which utilize, eliminates or guide the forces arising from muscle function, tooth eruption and growth in order to alter the skeletal and dental relationship. So, can you play the video? Can you play the video? These are the appliances which are used. Now it will just reposition the mandible into a forward position. This reposition will actually, with usage, will increase the size of the mandible and correct the facial structure of the patient. These are some appliances. So patient initially comes like this. I'm just showing the intraoral picture. Once the appliance is placed, the jaw has moved forward. If you see the second and the third picture, there's a drastic difference. Now again, class 3 malocclusion means the jaw really forwardly placed. In this, the maxilla is small, the mandible is big. We give some kind of play the video. Play. You give an appliance which is placed on the maxilla. We use chin as an anchor and we pull the maxilla out. So these are clinical presentations. Now come one of the cases which was this. I mean, if the child is not treated, what we do is, this is the, I mean, of course, this is a cleft case. You can appreciate the maxilla, it is too constricted. We give an appliance to expand it. Now you can see on the left and the right side, if you are able to appreciate, the maxilla is grown. In this case, the appliance was not only given for the growth prospect, it was also given for SABG, alveolar bone grafting, so that we can put some amount of bone to aid in the eruption of teeth. This is another case. We gave an appliance again to expand the maxilla. Now the last part is when you actually leave it. What happens is you end up taking the child to orthodontics and craniofacial surgery. I mean, in cases where the mandible is too big, maxilla is too small. We do default 1 osteotomy and PSSO.
Dr.
This is one of the cases. She was actually perpetually used to thumb sucking. Now her jaw is actually tilted. Now we have to do a surgery. So basically, the catch is if you do not do it at the right time, you will end up spoiling the facial structure of the child or the patient. And this is, if you can play this last time. Her jaw is shifted towards one side. I mean, she's not able to bite properly, sleep properly, or talk properly. So all these things can be actually eliminated if you actually diagnose it early and treat it.
Thank you, sir. I think it was very interesting topic. I'm hearing for the first time, listening for the first time. It was good to see you. Real joy to listen it. I think we should give you more time sometime to have an exhaustive thing on this because this is a very new thing for all of us. Thank you very much.
But the age limit of these procedures, suppose 7 to 11 है कोई 15 पे आ गया तो what will be the choice?
Yes, sir. That's what. If you come 7 to 11 is a range, we can try at 15, but success rate starts to decrease. The time period is very important. I mean, if you do not do between 7 to 11, then the treatment modality in itself will change. Growth spurt has happened at 10 to 11. Now 15, we cannot use the growth of the child to modulate its development. So anyway, we end up doing braces or surgery.
And what about that cap? You were saying that some second cap, but it is available. But
Yeah, it's custom. It's available. It's
Customized.
Stop.
Yeah, it's customized.
It can be customized also.
It is safe to use that cap.
So I don't give the cap, the hand cap. I generally design the plates. A lot of people do give that hand thing. Generally, what parents do is they wrap a clean cloth every day. Because if you use the same thing, there can be some amount of infection or something like that. Best is to tie cloth or use a long sleeve clothes. These are more things which are used. I mean, you can buy that thing also, but then you have to keep a lot of sizes. Which size fits? That is the thing. Better is to use long clothes that you can tell the patient, or tie a new handkerchief every day, or twice a day.
Any applying some chemical agent over this?
Astofidas they generally use. Sometimes some. Yes, sir.
Okay, thank you. Thank you.
Thank you. Speaker and chairpersons, please proceed to the felicitation area. So now we have a very important topic.
Former Secretary General IAP India. Please welcome and give a big round of applause to Dr. Vineet. It's an honor to have Dr. Vineet here. I would request Dr. Lalit Vaidyanathan and Dr. Mukesh Shankar to kindly felicitate Dr. Vineet Saxena.
Vaccination, history taking is most important. We often forget. As in every clinical case, we need history. There needs to be a thorough history taking. So the first dilemma is, Dr. Andromana, which are the vaccines which need special consideration when the child is allergic to eggs? We take history and we get to know the child is allergic to eggs. So what are the precautions for vaccines?
Nowadays, most of the vaccines which are manufactured, they do not contain egg, except for the yellow fever vaccine. Other vaccines like the rabies vaccine, now tissue vaccines we are not using now, and most of the other are in the chick embryo. So the egg exposure is not there. If a person has to travel, then he will need a yellow fever vaccine, which is the one which contains egg. So you have to be precautious about giving yellow fever vaccine.
For other vaccines, even if the allergy is severe, we don't have to take any precaution.
We can we can get a consult from a allergy person and hyposensitization can be done. The vaccine will need to be given.
So, now Arav, which has allergy to egg, needs yellow fever vaccine and he needs to travel to an African country. So, can a private practitioner administer the vaccine?
No, we cannot as a private practitioner because it is under the Government of India only.
The vaccine is available. In some areas, vaccine is available.
But how will we get the certificate?
Certificate. That is what
yes,
the question.
that is the
Is the
problem.
certificate issued by you is valid?
Yeah.
Because some people are giving.
No, it is only through the authorities, Our certificate won't be valid.
Yes. So we need to go to a dedicated center only for the vaccination and get the certificate. This is the website which can help. We have to take an appointment and so
Next question, Dr. Professor. Now, RR there is got bitten by a dog. So, is it really category 3? They get confused and contact you.
It's very simple. Category 3 is a category 3. It's not just it's a small bite or this thing. And rabies, we all know, being a fatal illness, you can't take risk. You have to take available. So there is no doubt in that.
Yes, so it is not the size of the wound, even if it's a transdermal bite, even a dot of blood, it is a class 3. There should be no confusion. Often this is the cause for fatality even after taken full exposure where RIG is missed. This is crucial.
And it's very important, medical legally we should write on the file, it has been advised, patient refuses, it is up to them.
So now RIG is implemented, ARI vaccine schedule is started, but on day 7 they can't get the vaccine. What should be done, Dr. NPC?
Actually, post-exposure prophylaxis regimen requires multiple visits. So there is a high chance of dropout. So there are certain general principles of this management of this missed dosage and some specific aspects. Like for minor deviation, like for few days, there is a missed dose should be administered as soon as possible. When you remember that it has been missed, you start, and the schedule start should be resumed from that point. And for specific, suppose if someone has missed, right in the question that the 7 dose was missed. So whether it is 7, 8, 9, whatever. So whenever patient comes, you give this dose as a 7-day dose, and then you start the schedule as per schedule, like 14 days dose should be given.
Maintain the interval between the doses.
Maintain interval, and 5th dose after 14 days of the last dose.
Right. So now during all this, the parents search a lot. They come back from African country to India, and now they report to you that their elder sibling also had a dog bite 1.5 years back. So, would he need the rabies vaccination?
The elder sibling is not bitten right now, so we will not need the rabies vaccination right now, and you have to take a complete history. At that time when he was bitten, what dose did he take? What
He
was
did
the
not
schedule?
take. He did not take the vaccine at that time. Now they report that he was bitten that time and no vaccine was taken.
So you can give him the vaccine, because rabies at times is known to occur quite late also. So he should take the full schedule then.
Exactly. The recommendation is even if the patient reports late, you have to take as if he has been bitten today and the vaccine has to be taken. So usually now it is recommended that RIG is given only at the wound site. Is there any indication for intramuscular RIG also?
I think it is always given in the infiltrated only if somebody is obese, and then more dose is very large, that remaining volume should not be small, it is injected IM. So as such there is no rule of giving IM.
And if there is a mucosal exposure or where it cannot
you can use the local applications of the immunoglobulin. You can just apply it locally with this solution also, local over the lips also, over the sides of the tongue. You can apply that local application can be done on the cuts and the wounds of the mouth and the lips.
As per NCDC, in past bites also, if the wound has already healed and patient has come late, then also we can use intramuscular.
Yes.
Closest to the site of the bite. So now, cow dies of rabies. Is rabies prophylaxis needed for all those who have been consuming milk of that cow? Dr. Vanju.
Actually, consuming even milk of a rabies animal, it won't cause rabies because there is no proven cases of ingestion of milk and causing rabies. It only spreads to either there is a bite, exposure to some saliva, lick wounds or like that. So this is
It
not
was in
proven.
media recently in Ghaziabad case where there was such a thing.
No, theoretically, data-wise, it is very clear it doesn't cause.
But those who had handled the cow, they might need.
It all depends how much the open lesions they have in their hands and everything.
Exactly. And second is, what is the child licks on the ice cream wrapper which was licked by a cow or dog maybe?
Again, see the rabies virus, it is so labile, it doesn't live beyond minutes outside the animal. So it is, even saliva was touching that wrapper and it has been outside for more than minutes, it will get destroyed. So it will not cause.
Exactly. In both the scenarios, the vaccine is not needed. No need to panic. So rabies is 100% fatal disease. We are the rabies capital of the world. We have an excellent vaccine. Still, it is not an universal program. We are giving vaccine which is lower efficacy, and we are not giving this vaccine as a routine. What is the reason, Dr. Anjit?
Ideally, over the years, it should be included in the immunization schedule. But government at times includes the vaccine in the immunization schedule based on the epidemiology. It may not be present. So you can prevent dog bites, and 1-to-1 pre-exposure prophylaxis should be given, and pre-exposure prophylaxis should be given if they have a pet, or if there are like health workers should get it, laboratory personnel should get it as of now. And later on we can include it in the immunization.
Time has come to think about it.
Think about it.
So another deadly disease, meningococcal disease. Again, IFP does not recommend it for routine use. Still some people are using it. What is your take, Dr. Anjit?
So it has two components. One is that why IFP has not recommended that. The main reason is that in our country, the true estimates of meningococcal burden remains unknown, which is due to the poor surveillance methods and also the limited diagnostic technology. And whatever data have been collected from the various authorities and from the data from the public domain, they are not available in the public domain. And they are often unreliable due to multiple antibiotic intake in our society. So despite the frequent outbreak reported in the country, the surveillance system is not good. This is the reason this has impacted the authority to take, or policymaker to take any further concrete decision regarding the implementation in the government immunization. But as your second question that many patients are giving, that is a totally clinical based answer I can give you, that if you go by the most recent meta-analysis of various studies, they have seen that still meningococcal disease are occurring in outbreaks, or some both are epidemic and endemic in various parts of the country. So in our country, this vaccine is considered as a good to give vaccine. So what is the good to give vaccine? Those vaccines which are not recommended, but they have been proven to have safety, efficacy, and they have proved to be reduction of the life-threatening diseases and cost-effective health interventions. So they can be used as a good to give vaccine. We know that the effectiveness of the meningococcal vaccine is from 66 to 100%, and they are approved and licensed in our country. So if someone, parents want to know, clinician can go to give this vaccine as a good to give vaccine, but certainly take a proper consent, explaining all the things, and take a written consent, and you can give as a good to give vaccine.
So you decide that vaccine is to be given. Then how durable is the vaccine? If you give one dose at 9 months, how long the child will be protected?
No, the IFP.
Like Dr.
I think the meningococcal vaccine, the antibodies usually wane over a period of time, and the studies have shown the antibodies declining after 3 to 5 years. So depending upon the age, the individual response of the person is exposed to meningococcal infection, then those individuals need to be revaccinated. Now this period is different for different. So for meningococcal ACWY, they recommend the booster at every 5 years. In fact, below 5 years, they say even after 3 years if the person is exposed to childhood. And in case of meningococcal B, they recommend it after 1 year.
Exactly.
So basically,
So
because the declining of the antibody response and the person is exposed to meningococcal, we should revaccinate the individuals.
So even if we give the vaccine, we decide to give the vaccine, it can give a false sense of security. It is not going to give a long-term protection. And remember, the second peak of meningococcal is in the teenage. That will be missed. So one is to be clear when you are giving vaccine, you have to tell the parents that is not going to be effective for a long time. So that is the point to be taken care of. So influenza vaccine is recommended annually, Dr. Manipur sir, but is durability good enough to cover for the whole year?
See, mainly what it is going to cover is your peak season. So when you are giving just pre-monsoon, say August or July, that is going to cover. Initially the peak comes in next 3 to 6 months. So that is the purpose. Actually the protection lasts only 6 to 12 months, and the younger the child, lesser the protection lasts. But still the protection doesn't go to zero. It may be 10%, 20% less, and also it varies how much is the vaccine strain match actually. How much is that year the match? The more the match, the more longer it will last. So that is.
It is good for West, where they have only one peak. We have 2 peaks.
So that is very clear. When you have 2 peaks, you have to give the latest vaccine available with this. That is when you start with your vaccine.
So Dr. NP Singh, what is the best time then in India when we have 2 peaks?
So as Dr. Manish Gupta sir has said that it is depending upon the peak. In India, the latest literature over the zero positivity or occurrence of influenza has shown that we have the 3 zones. One is temperate zone, that is from the extreme north, like Jammu and Kashmir. They are their highest peak season is December and March. So this considered as a temperate season zone. Second is the central part. The various authorities consider Delhi as a central part, not in the north. So the east, west, and Delhi central part considered as a monsoon peak, and the South India as the late monsoon peak, or you can say the winter peak. So depending upon that, we have to give the just before. So the best practice is that whatever is the season, you give at least 2 weeks from the start of the season for its most effectivity. And most important thing is that if someone had missed the season, still you can give the vaccine, because vaccination is the more important than the seasonality. For a specific approach, one thing should be clear in mind, that if some smaller kid, like their influenza vaccine has started for the first time, like 6 months age, there you should not wait for the proper season or proper time. So you give the first dose at 6 months, second dose at 7 months, irrespective of the season. Then from the next season, for the booster, you try to accommodate in the best suitable season and region wise.
The problem occurs during the change of season. We hear a child gets the vaccine, and when he comes for the second, when he is getting for the first time, 2 doses are recommended at 1 month interval. The child, when they come for the second dose, the strains have changed. The new vaccine has come. You have now both the doses, the old strain also, the new strain also. Which one would you give?
You can give the new strain for a better coverage. Secondly, regarding the northern India, eastern India, as well as western India, the southern hemisphere vaccine is usually given in the months of April. It is pre-monsoon, April to June, pre-monsoon. In South India, as already said, we can give the vaccine in September, October. That time we get the northern strain vaccine. That is how the vaccines are being given.
The dilemma is, if we give 2 doses or 2 different vaccines, antigens we are giving, would it lead to suboptimal priming? Because
maybe some of them will have some optimal priming, but there is an added advantage of having another strain.
Exactly. So both the approaches have some positive and negative. Dr. NP Singh, now we shift gears from influenza. The child has nephrotic syndrome. Would he require influenza vaccination, and when it should be given?
Yes, actually nephrotic syndrome per se is not considered as any immune suppressed condition unless child is on treatment, high dose steroid for a prolonged period, that is more than 2 milligram per kg for more than 2 weeks duration. So if at that time, it is particularly true for the live vaccine, not for the kill vaccine, but it is safer to wait for some time, at least 2 to 4 weeks, because the responsiveness of that kill vaccine also low if the child is on either immunosuppressive drug or immunosuppressive condition. So in our country, all the vaccines available are the killed vaccine. So we can give in nephrotic syndrome, but if someone is on the high dose steroid, means the daily dose steroid, then we can wait either at least 4 weeks after the completion, or if shifted to the alternate dose, then we can safely give the vaccine.
Right. So if the child is above getting dose for more than 2 weeks or more than 2 milligrams per kg per day, then considered to be immunosuppressed. So there is another case. Arjun is now 10 years old and has come to you for a long time. After a long time, you take history and you get to know that now he has steroid-resistant nephrotic syndrome, not responding to steroids, MMF, and now received rituximab, the immunomodulator 5 months back. How will your advice change for vaccination? Dr. Anjul.
Rituximab is basically acting on the B cell immunity. It suppresses the B cell immunity. So no live vaccine has to be given. And if it is very essential, then we can give the other vaccines, but the immunogenicity of the vaccine will be doubtful. Influenza vaccine is given at times because these children are more prone to infection, and we can plan out the other vaccines as per this schedule, mainly 9 to 12 months after rituximab.
And what about the past vaccines? Because it is an anti-B cell product, it will kill all the memory cells.
Yeah,
so even the past vaccines have to be repeated, I think.
Yeah, that was, all of them have to be repeated.
All of them. Because all the memory cells are gone, the child becomes immunologically naive. All vaccines, past vaccines, age-appropriate vaccines have to be repeated. Another special condition is autoimmune condition like SLE, where immunosuppression is the mainstay of treatment. So, Dr. Mendeta sir, what additional vaccine?
Like any immunosuppressive state, as Madam was saying, so we have to take again the precautions of the live vaccine always. We should always avoid unless there is a risk of exposure. And as far as the important vaccine in the immunosuppressive state in SLE are concerned, again the same things, kill vaccine with the conjugate vaccines of influenza, pneumococcal, meningococcal, HPV we can give it. And the important thing is that the suppression is because of the disease, and sometimes the child is on medicine, immunosuppressive medicine. So there are few recommended doses for azathioprine and cyclophosphamide that you have to take care of. And otherwise, if the immunosuppression you want to quantify, what is that, you can go the help of the lymphocyte count, the CD4 counts that can decide that child has been. This depends upon the level of exposure and how threatening the disease is the child is exposed to it. So the kill vaccine, of course, when the immunosuppression is stable, you can always give it. Pneumococcal, influenza, meningococcal, and HPV.
So we need to try to time during the remission phase when the dose is low.
And we have to give at that time when immunosuppression is stable. So we take the help of those lymphocyte counts, CD4 counts.
So we shift gears. Now the typhoid vaccine dilemmas we take. Recommended currently single dose vaccine at 6 months. Current data, number of studies, Bangladesh study and Malawi study shows that single dose may not be sufficient. So what is your take? What do you recommend in your practice?
Definitely this has happened in our practice. Initially we used 2 doses of TCV, then we started using 1 dose, and now we are having doubt of over 1 dose whether we require second dose or not. So as you already show the recent data, first Navi Mumbai study was there which showed the single dose is good enough, but that was for 3-4 years. Now the main thing is the waning of immunity in 3 to 5 years, as these 2 studies, Quadri et al. And Patel et al. They show this. So also we did a study at Jaipur Golden Hospital. Last DNB submitted this thesis. More than 80 cases were diagnosed, more than 60 were blood culture positive, 12 were typhoid vaccine taken patients. Out of this 12, 7 had taken single dose of TCV, none had taken 2 doses of TCV, 5 had taken unconjugated. So all this data shows you definitely need, now we practice 3rd dose after 3 years. And maybe IEP soon come with more guidelines, maybe they also say you can give second dose. But practically most of the pediatricians now are following more than 3 years gap, you give a second dose.
We now have studies for 1 and 2 doses. Later on, after 2 doses, we have to see how long the effectiveness is.
Those are rare cases. I have few, but those are rare cases till now.
And is there a difference if we give the first dose at 9 months, or if somebody gets at first dose at 5 years? Will it make a difference, Dr. NPC?
No, difference is that it is a slight milder difference is there. अगर 5 साल तक नहीं हुआ तो dressing for this like group बच गए, because the maximum seropositivity declines by the passage of the age, and it is says that in earlier years it gets declined. Then after that, at 5 years interval, it was seen that the seropositivity was also highest at that time. So if someone has taken at that time, if you compare from the smaller kids who are at the 5 or older, then the effectiveness was 73%, that 87%. So faster waning of protection under 2 years was compared to the older children. It was found that the highest burden of disease occurs between 5 to 9 years age. So that's why giving at that time will not, if not superior, it is not inferior to that, because it purpose 3 is of 3 purpose. One, there is an increased efficacy at that age group. Secondly, there is a decrease in the decay of the antibody level. So thereby there will be the prolongation of the protection. And third, in that case, there will be a sparing of one dosage. So given at 5 years is quite as good as the given at.
It should be better. Immunity is better at older age, and waning is also less. So a child has received a single dose of TCV as per current schedule and develops a culture positive typhoid fever, as Dr. Gupta sir was saying. Now, would you give the second dose?
Yeah, you have to give the second dose after 6 weeks of the disease, and you have to practice sanitation practices. That is important. Water supply, etc. is important, And in all these typhoid vaccines, they are not 95% efficacious. They are up to 60-70% efficacious. Then we have incidence of paratyphoid also occurring. So that makes them more important.
Even after 2 doses, there will be cases, so wash is important.
Wash is important.
And so even if he gets a typhoid culture positive after 2 doses of TCP, then what will be the recommendation? Only wash or?
He will give a repeated dose of the vaccine after 6 weeks of the disease.
If he has suffered already, he has already taken 2 doses and then gets a culture positive.
You can give the 3rd dose and investigate for paratyphoid, investigate for immune deficiency.
I am also confused.
Still when you get.
After decision.
See, there is no history and data of giving 3 doses. There are data of 2 doses. If something wrong happens with the 3rd dose, medico-legally you will not be safe. So better is to stick to what has been practiced and recommended by science. Just go with.
मैं 2 में हम कहाँ सेफ हैं? हम पहले में भी सेफ नहीं हैं. पहले में कहाँ सेफ हैं? पहले के बाद भी हो गया पेशेंट शाउट से 10 कि आपने वैक्सीन लगाई थी हो गया तब से. सेकंड के बाद भी हो गया.
We have something to back on. We have a guideline. We have a recommendation. As of now, we have studies for 2 doses, recommendations for single dose. So medically, there is not a problem even with single dose. Harassment, there is the study we are discussing. There is difference between harassment and medical legal thing. So we can get
the antibody levels, whether the vaccine is effective or not.
And always the controversies there regarding COVID vaccines. We still keep getting so many queries regarding COVID vaccine and cardiovascular mortality. It's always in the news. So what does the
current evidence says that vaccine has been very effective. In fact, it is beneficial for patients with cardiac patients also. It has reduced heart failures in cardiac patients, reduced mortality in heart patients. There is no risk of heart attacks also. Of course, there is a very minimal risk of myocarditis in young individuals, which has been seen with the mRNA vaccine, right?
That is mild and usually manageable.
That is the only thing. As far as the current evidence, it is absolutely the risk of cardiac mortality has decreased.
Cardiovascular morbidity associated with the infection is much more than the data of the vaccine. That even the latest ongoing studies have shown.
So it is beneficial overall.
So as far as COVID-19 vaccines are concerned, India today is at poles apart. West is recommending vaccines routinely even for children. We don't have vaccines even for the high risk group. So what is that? Either one of us is wrong, either India or West. We are not giving vaccine to anyone now. West is continuously giving upgraded vaccine. WHO is also recommended upgraded vaccine. And we don't have vaccine even for the elderly, for those with COVID.
Actually, our priority has been shifted to the other things due to many reasons. We cannot compare Western data or with the Indian data. We can say that in our country, we have just exhausted with the multiple dose of vaccine. The difference is that our public health philosophy and immunity profile, these matters the government decision to give or not to give. Because due to multiple waves of infection, we have attained the hybrid immunity due to natural disease and vaccination itself. Similarly, persistence of some Omicron variety that causes the less severe disease. So these are, for general population, the risk of serious illness requiring vaccination is very low. As compared
but they are giving vaccine, upgraded vaccine for Omicron only, which is a major.
Yes, but public opinion is against that, yes, because it is not severe, so we have already taken the multiple dose. Second, public becomes fatigued. If you see the data, it is collected between 2023 to 2015. Initially, in the Q1 of 2023, active booster campaign was given at that time. Second quarter, there was sharp decline in the giving the vaccination. Then, at the 4th quarter of the 2023, almost it was halted. In 24 second quarter, minimal residual dose was given, and last in the 2025 symbolic given. But still, it is not being true that it is not being given. It is given weekly for those persons. Like suppose if somebody is traveling to another country which requires vaccination, some elderly, some high-risk patients, some immunocompromised patients, still government is giving on the required basis. And their portal is already open. You can ask they are giving the answers to the frequently asked question of that. And last, their priority is shifted to the other important vaccination. That's why COVID vaccination gets slightly back.
Thank you, sir. Thank you.
Yeah, thank you, panelists. I think immunization discussion will go on and go on. We have shortage of time, so I have just only one question. So most of the time we give IVIs in the course. So the question to our panelists: so what is the recommendation of vaccine after IVIs?
There is a different. It depends on the dose of IVIG. After blood transfusion, after IVIG or plasma transfusion, vaccines have to be at least stopped for 6 months. Most of the vaccines, measles maybe from 9 to 12 months after the immunoglobulin.
Varicella also. It depends on the vaccine.
Vaccine as well as the dose of the immunoglobulin.
There is a separate chart available, I think in Nelson also.
And vaccine plus disease like Kawasaki, 11 months is the
depending on the dose
of IVIG, not disease, dose of the IVIG. When we are given 2 grams per kg, then 11 months for.
Oh my God. Thank you, Puneet. You have asked really problematic questions, and but our panelists are also very have a contributing answer. But one dilemma I still feel about the typhoid vaccine only. It's so common, typhoid. I mean, I have seen quite a few patients who have taken 2 doses, still having, and now still got to do. Until said, you should do the antibody levels. This is the antibody concentration to be done. If it is there, then why should he have a typhoid? If the antibody level is good and all. So it means still.
Actually, my one take on this matter is that actually what happens that even after 2 doses of vaccination, if someone is having developing typhoid infection, there must be 2 reasons. Either vaccine is at fault or host factor is at fault. So, because we cannot tell that vaccine is at fault, because salmonella is an inoculum-based disease. So probably even 2 doses cannot do their work. So we cannot then even in that case 3rd dose.
No, the dilemma is in the 3rd dose. That's what I'm saying.
So till the guidelines comes, 2 doses recommendation is still there.
Thank you.
A big thanks to Dr. Puneet for nicely framing the questions and moderating the session. Thank you.
Thank you, and thank you to the audience, as always, being patient and presenting at this last.
This chairperson's panelists, the speakers, please proceed to the felicitation area. Now we come to the topic in neonatology. How use of innovative technology improves outcomes in NICU. I call Dr. Abneet Kaur to give a presentation.
I really first of all thanks our organizer for giving me opportunity to speak on this topic. And as we know, the technology has started taking whole of our life. So our daily life involves use of technology. So that's how the technology is now venturing into our healthcare system. We all know that technology use is being used in our home automation, our mobiles, for our booking our tickets, for our banking, everywhere we are using technology. So technology use is coming in a big way to venture into the healthcare and change our dynamics of using the technology, using the techniques to improve our healthcare system. So we all know that our NICUs have progressed over years together, but the problem is that the number of devices to which our babies are connected have not changed over the years. So you see all the babies in wired all together. So there are millions of data points which are being gathered by use of technology, but all these are being used manually, and that leads to what is known as the human error. So why do we need smart NICUs? We need smart NICUs because of the complexity of the equipments, the longer stays of the babies, the better survivor of our babies, but at the same time, it involves the use of lot of equipment and lot of injuries to the skin of these babies. Our workflows, like the use of sister's chart, the doctor's chart, the EMRs, they have they're very intensive. So how we can use technology to reduce the burden on our staff, to reduce the alarm fatigues in our NICUs, and how we can work these things from manual to which is non-manual techniques. That's the focus of this presentation. So the concept of smart NICU is that how we can integrate our electronic health records into data-driven techniques how the artificial intelligence can help in better predictive analysis of our babies, how the advanced diagnostic tools and equipments can be used to better healthcare technologies, how the point of care ultrasonographies and echoes are being used, the telemedicine which can help us of better care to the babies who are not in the central part of country or maybe are in small NICUs, and how eventually we'll land up in using better screening and genomics to our use. So what do we mean by smart NICU? So the NICU which I work, we are part of a smart NICU. We use e-NICU technology where we are trying to get things where there are in automated loops that we want to prevent oxygen toxicity to our babies. So we want to get a loop where the pulse oximeter predicts that this oxygen saturation is going high and ventilator automatically gets our FiO2 down. We want to use techniques like, we all are using automated blood cultures. We want to have a better predictive analysis. So we are using monitoring predictions so that we can early predict that this baby is going to land up in sepsis in next 24 hours, 48 hours. How we can predict that if the doctor is not available, then how the retina cams can predict that, okay, these are the figures which are like ROP stages. And also we want to use combination of multiparas, the equipments are integrated to devices. So what we are using this e-technology as that, like you can see that this is the baby, it is connected to the ventilator, it is connected to the EMR system, and they all show the data onto our iPad, which collates the data from the lab, which collates the data from the lab system, it collates the data from the baby's EMR, the ventilation, the warmer, so everything is on one particular device. So I can see my baby from home because the baby is being captured from the camera also. So this is what the technology is like changing over time. So as you can see, this is how we take the rounds in our NICU, where we are using the tablets and we are like capturing the data of the baby, the video of the baby, everything on one particular interface, and we get the sisters' data also on this, and the sisters don't have to capture the vitals of the baby, which is being captured every minute by the machine itself, and their work burden has reduced over time. So our system looks like this. It gives a holistic 360-degree view of the baby, where we have the neonatal scores, we have the growth charts, we have the medication calculators, we have the calorie calculators. So everything is on one single dashboard. We can also give the holistic view that this baby is sick, this baby needs like early, round for the baby. So nutrition, everything is like in one single platform. So I'll fasten up the presentation because we have less time. And we have the jaundice monitoring things, everything on. Ret cams, ROP screening, you didn't need a retina specialist. Now, like we have infrared temperature monitors, we have cameras fitted into that temperature monitoring. You just go near the baby, dilate it, and you will be able to capture the screens, and the AI will be able to tell that what stage of ROP the baby is in, and you don't need the use of doctors to predict that, okay, this baby needs what management. So a lot of studies are being published for the use of technology, and last but not the least, the genomics. AI is coming in big way to use of genomics, and eventually long term, we want to study every baby who's getting into the NICU, use of genomics and use the predictive treatment of those babies based on the genomics. So I think alarm fatigue and all. Again, lot of diseases where we are using the use of artificial intelligence. Probably I not have time to get into too much details of all this. Point of care ultrasonography. All the MRI radiology centers are using AI to judge what kind of diagnosis or what pictures we are. We are using like artificial intelligence in point of care ultrasonography, where the machine when put on the baby will tell us, okay, are you on the right position or you not on the right position. You need to angulate the machine so that you get the right picture. So, just simple video. I don't know if the audio is there. Audio is there. Okay. So this was just a small video where just it came 2 weeks back, which showed that this doctor did the surgery. It was a renal implantation surgery done by a doctor sitting in Gurgaon, and the surgery was pyeloplastic surgery, which was done for a patient who was in Hyderabad. So robotic techniques and the telemedicine techniques are venturing into a big way. That this all is possible, that somebody surgeon is sitting in Delhi and doing a surgery for a baby who is in Hyderabad. So I think I'll cut short my presentation, and I think this is my concept, so since there is no video, but it is my concept of a smart NICU where the baby will be wearing smart devices, just 2 devices. The robots will be there to make our medications, and the parents will have the telemedicine to see the thing for their baby with as less as possible of sensors, and lot of technology being used to help the outcome of these, better outcome of these babies. So the last thing which I want to say is that doctors cannot be replaced by technology, but the doctor who does not know AI or technology will be replaced. So it's a high time that we all venture into it. The doctor will not be replaced though. Thank you.
Thank you, Dr. Abhi.
द्वारका टैक्स देके जाओ हमारा द्वारका का इनाम द्वारका में ही रहेगा
So the lucky draws are done. May we proceed with the presentation, Dr. Please.
Poor milk supply, and sometimes we can have a persistent jaundice. And you know how the breastfeeding works. It starts working right from the 16 weeks. The moment the placenta come out, there are a lot of hormones come, and the moment baby comes out, they are ready for the feeding. If you keep the baby and mother away from each other, then the chances of breastfeeding failure would be very high. So the chances of breastfeeding failure would be very high. So you start skin-to-skin contact, 0 separations policy, and start early initiation of feeding would be a successful breastfeeding. Day 1, day 2, the colostrum is needed, and then by day 3, day 4, the milk supply would be higher. The reasons for the low milk supply are not primarily would be means that there would be some breast surgery, there would be some hormonal issues like pituitary and hypothalamic injuries, some hemorrhages, they can lead to primary failure of the breastfeeding. However, the secondary suppression is much more common because of the low oxytocin and oxytocin inhibitions, because of the mother has received a lot of syntocins during that, the delivery is traumatic, and if you keep the baby mother separately and you offering alternative feed like formula immediately after birth, then it will not initiate the breastfeeding, and successful breastfeeding would not be there. And obviously the latching problem is one of the issues. So we should understand that the most of the time breast don't fail. It is the other reasons which would lead to the breastfeeding failure and feeding failure. So while at your OPD you ask only 3 questions to the mother: is the breastfeeding is painful or not? If it is not painful, that means the latching is a good latching. Look at the output, ask 2 things: what is the urine output, what is the stool output, and you have to look for the color of the stools and the number of the stools. The color of the stool, during the first 48 to 72 hours it would be green in nature, and beyond 72 hours it would be yellow. If these things are not there, then chances of suboptimal breastfeeding would be there, and the poor weight gain would be there, and chances that baby would be having persistent jaundice. And the weight record is important. Weight record is important in that view that more than 4% weight loss in a day is considered to be abnormal, and more than 8% weight loss, up to 10% weight loss beyond 48 hours considered to be an abnormal weight loss. So these 4 things are important: that painful feedings, output in form of stool, number of the stool, and the color of the stool, and the weight. These 3 would give you enough evidence suggestive of what is the cause for the poor breastfeeding. So this is the case 1. One of the cases that 4 weeks old baby born at 39 weeks of weeks of gestational age, the birth weight was 3.2 kg, and even at 4 weeks the weight is 3.2 kg with clothes. Mother was very motivated, says that baby is feeding throughout the day, still irritable, fussy, passes urine 10 to 12 times in a day, but baby is not gaining weight. The red flag sign is that baby is not gaining weight. But when you ask about the output in form of urine and stool, urine baby is passing, but stool baby is not passing, then that means the possibility that baby is underfed. Then you have to look for the lactational support, look at the latching. The second question is that whether the feeding is painful or painless. If the feeding is not painful, that means the latching is appropriate. So if there is no painful breastfeeding and still baby is not gaining weight, then you have to look for other reasons. Probably baby is losing too much of energy while taking breastfeeding. Then again you have to look for latch assessment and then ensure that baby is having a good latch. Still that, if the baby is passing good amount of urine, stool, no painful breastfeeding, then there would be a chances of very, very rare pathology which would lead to breastfeeding failure. So most of the time what happens, you in place of correcting the latching process, you end up adding many things to increase the weight gain. You start adding MCT oil, sometimes you start adding HMF, some you start adding alternative feeds like a formula to increase the weight gain, but probably you are not looking at the actual reason for not gaining weight. So this is the second case, 36 weeks, slightly premature baby, normal vaginal delivery, birth weight was 2.7 and current weight on day 7 of life, weight is 2300. As I told you that anything 8% weight loss is abnormal. So here is baby lost almost more than 10% of weight loss, wasn't exclusive breastfeeding, pre-discharge bilirubin was 12, on early follow-up, advised because of the high pre-discharge bilirubin on day 6, it was still late, there was no risk factor of hemolytic jaundice, still baby having down jaundice, required phototherapy for 2-3 days and was discharged. Again was re-admitted on 22nd day of life with a very high jaundice. So that means the jaundice was persisting. So that baby was labeled as that, probably the breast milk and feeding related jaundice. Actually, if you look at the 3 things, that it was not painful breastfeeding, output was low, baby was not gaining weight, so most likely baby was not getting enough milk. Because this baby is slightly premature baby, their livers are not that mature for conjugation, that's why jaundice was persisting. Here you have to ensure that probably there are 2 maturity, one liver maturity and second is the gut maturity. These 2 factors is important for the excretions of the bilirubin. So here baby was not getting enough milk because of the gut maturity, that's why we was not passing enough stool, and they were not passing enough stool, that's why jaundice was persisting. So there is no point chasing jaundice in a preterm baby, specifically those who are between 34 to 37 weeks. They can have persistent jaundice just because of prematurity. So don't chase, ensure that baby gets enough amount of milk. If not, ensure latching. If not, then express breast milk and supplement with milk. And rarely we do supplement alternate feed if in case there is some issue with the mother. So at discharge, you just mentioned 2-3 things during follow-up, that baby should get 8 feeds, 8 times stool, that would be enough. So just give you 1 or 2 minutes now. Okay. So this is the baby. This is 37 weeks, twin baby. One baby has been weight of 2.4 kg, another one was 2. Tongue is coated and tongue is not moving out completely. There is some tie which can be seen. The another twin was on bottle fed, because in case of twins we found that many of them on bottle fed. You can see the one baby having coated tongue, another baby having lot of coating not only on the tongue but also on the gums, on the cheek. This is a case of oral thrush. Another baby, because tongue was not moving properly because of the tongue tie, so it is not getting cleaned over the palate. So normal tongue moves over your palate, that's how it got clean, and you don't allow any newborn to clean the tongue. So here, the case was because of tongue tie in one of the twin, another twin having a oral thrush. So if you found oral thrush in an OPD basis, treat at least for 14 days. If you treat less than for 14 days, the chances of recurrence rate is 60 to 65%. So because they do improve within 72 hours to 4 days, but try to complete the course for 14 days irrespective of the response. 14 days, 14. So one case during summer, 40-week baby, 3200 grams, readmitted with again abnormal weight loss, more than 10%, and poor feeding. But you can see this baby had a very bad tongue tie. This baby was not feeding. Otherwise, baby is active, crying a lot. There was no signs of encephalopathy because of the hypernatremia. So there are a group where tongue movement is inadequate, so that they cannot latch properly and leading to failure. So in that case, probably you need a more lactation support and some exercise for these group or baby to improve their feeding, and so that they don't lose abnormal weight and then they don't require readmissions. So we observe tongue movement, we look for the breastfeeding and we palpate tongue to look for abnormal. This baby was born after priming. Mother was very adamant for normal delivery, so it was pushed for a longer period, and baby born slightly depressed, required minor resuscitations, and was admitted for observation in the NICU because of the requiring initial steps. You can see the baby neck is slightly deviated. So what happened? So while pushing the baby during the time of normal delivery or assisted vaginal delivery, your neck get extracted. I mean, the neck got extended, and because of the extension of neck, if you extend your neck like this, all the muscles over the tongue, got stressed. If you can try this, then you can feel that all the tongue muscles got stressed. So because of the tongue trauma, it's not related to tongue trauma, because all the muscles related to tongue, they got stressed and they got damaged, and that's why the tongue movement is not adequate. So this baby was labeled as asphyxia and was not feeding well. So because not feeding well, because of this is a functional tongue movement related disorder. So they would require more support, more assisted feeding, so that you have to buy some time to improve the tongue muscles, health, and generally they would improve within few weeks. So reason of this false tongue tie is because of at the time of cesarean, you push too much of pressure, too much of syndrome, you apply assisted vaginal delivery, they all can lead to extension of the neck, and this extension of the neck can damage the muscles, and they can lead to the functional tongue related problem and latch, abnormal latch. So one is that you found that there is abnormal muscles which causing a true tongue tie. Other is related to stretching of the tongues, can lead to the false tongue tie or forked tongue tie. They would require lot of support. We call it a body work. Body work is like an occupational therapy. You try some occupational therapy related to tongue and improve the latching of the baby. And rarely they would require some surgery like a phenotomy in very rare cases. Even though we found that tongue tie is there, we don't, label is a tongue tie. We follow the baby closely. We know that they can have some problem while feeding, and definitely it's a time to get help for good lactation consultant who have the idea of treating this patient. If they don't know these group of patients, they won't be able to treat all these patients. So at your clinic, look three things. Ask to the mother, is it feeding is painful? If the answer is no, that means the latching is appropriate. Look for number of the stool and color of the stool. By 7 days, if the color of the stool is yellow, mustard, watery, it's a breastfeeding stool. Very good sign of a good feeding. Ask for what is the baby is sleepy after feeding. That's a very good sign. If the baby is irritable, firstly, that means baby is not latching is inappropriate, and they can have lot of gas related pain, colicky pain. And obviously weight, all pediatricians look for the weight. Any weight loss more than 8% is abnormal weight loss. And if required, express breast milk, supplement. Don't jump for formula. Look for the actual cause, because generally breast never fails. Okay? Thank you.
This is painful, and the child suffers as the loss of weight gain and becomes cranky and fussy, and the cycle keeps repeating. As pediatricians, we most of the time think counseling is the best tool. Yes, it is the best tool. If we know what is exactly happening, it is the best tool, because nature will overtake the procedure on its own time. So we should never go for a quick answers to most of the questions, or not try to supplement it with something which is not provided by the nature. Give it time, and I think once we know the root cause and we are on the right track, we'll get to the right answers. That's my tip to it.
Thank you.
Thank you.
Thank you, West team, for giving this opportunity. And in the interest of time, I'll cut short my initial slides and we'll talk more on management. And so we all know anaphylaxis is a fatal event, not only in an emergency department, it can happen anywhere and in any OPD. Per se, not pediatric or medicine, in any OPD. So let's start with a case quickly. A febrile child of 7 years, suppose given a 10 ml of Brufen and 30 minutes later found to have a severe abdominal pain and arterial rash. Now, is this anaphylaxis?
It may be, it may not be, we don't know. Should I administer an adrenaline as a doctor? What would be the best route? What would be the site? And now after treating this child for anaphylaxis in an emergency, how should I monitor this? How should I plan? Should I admit this? Should I observe this child for how long? And what should be the discharge plan? So just quickly, anaphylaxis is a severe life-threatening generalized or systemic hypersensitivity reaction with many different mechanisms, different triggers. Every child, every person will have different saving any anaphylaxis shock. So we have found criteria, but we are following World Allergy Organization anaphylaxis. So this is something important, so I'll take a second on this. So any acute feature of skin or mucous membrane, right from pruritus to edema, along with any systemic illness, whether it is airway, circulation or gastrointestinal symptom, presence of any allergen, history of any allergen exposure is not essential. So this is considered as anaphylaxis. Secondly, if person comes with any evidence of serious or respiratory involvement in the presence of an allergen history or a known allergen, that is also considered as an anaphylaxis. Here the involvement of skin is not essential. So we need to have a high degree of suspicion when we treat anaphylaxis. Anaphylaxis can be immunological, non-immunological. Immunological causes, we have food allergens and aeroallergens, and insect and venom allergen is very common. Non-allergen is through IgG complement mediated. Here radio contrast media is important. So care should be taken in MRI and CT scan rooms. Then direct mast cell activation can also be there. So a quick, we all know how this allergy cascade happens. So a second exposure to an allergen can lead to a mast cell activation and an allergic cascade. So these all are the triggers. I'm skipping this. So clinical features we know. It can be the skin features, respiratory, cardiovascular and gastrointestinal features. But in case of an infant, being a pediatric conference, we should be very specific. Infants will present differently. It can be from mild, simple crying, fussiness, clinging to the mother, to a sudden floppy infant. When we don't have any other history, we should think of anaphylaxis, and history of allergen exposure may not be essential in these cases. Now, any diagnostic test we don't require. It is a clinical diagnosis, clinical history and a big degree of suspicion, that is all required. But still, tryptase level can be done. Tryptase level usually peak around 30 to 90 minutes, but just for a tryptase level, we will not stop our treatment. Treatment will start in the first go itself. Then histamine level can also be done, but it has a very short half-life, so it is usually not important. Then this is important because we need to know why we need to monitor and whom we need to monitor. So anaphylaxis, usually the symptoms peak around 15-20 minutes to 2 hours, and then they subside. But 20% of cases do have a biphasic anaphylaxis features also, which occurs after 8 to 12 hours. That is usually in case of severe cases or when there is a late presentation or the treatment has been started after 1 hour of the symptoms. Or in case of food allergy, where we feel that the food allergens may be absorbed after few hours, so we can have a second phase. So we should always keep in mind the second phase and then advise our patients for any observation, monitoring or hospitalization. So management here, any emergency, it is a ABC, but we have it as BABC. Drugs first, followed by airway, breathing. So any emergency should have a written protocol. All the staff, residents should be totally taught about this, and an early exposure remover of the trigger should also be done simultaneously. We know these are the 3 groups of drugs. And adrenaline, that is the first line of treatment. There is no absolute contraindication to adrenaline, and simultaneously along with administration of adrenaline, it should be the airway management. The IV line should be secured, oxygen through a non-rebreathing mask should be given, and treatment for hypotension and bronchospasm should be started with vasopressor or other drugs. Then antihistamine glucocorticoids, these are just the adjuncts. The major role is of the epinephrine. And so epinephrine should be started first. It can be given every 5 to 10 minutes as per the conditions required. It comes in, sorry for this overlapping. It requires in the concentration of 1:1000 solution, that is 1 milligram per ml. Adult 0.2 to 0.5 ml, child 0.01 ml per kg in lateral thigh, and if it is not possible in lateral thigh, be it any age group, newborn or an obese patient, it should be lateral thigh, and then we go to deltoid. Second is deltoid, because lateral thigh, it is a big muscle, so route of absorption is better, and it has to be IM. It is not subcutaneous, it is not intravenous, and now there is no controversy regarding that. So auto-injectors are there, but auto-injectors is useful only in in the weight group of 10 to 25 kgs and 25 to 50 kgs. In lesser than 10 kgs and more than 50 kgs, auto-injectors, the dose is either not full or it may be more. So antihistamines, I told you, it is only used for the adjuncts. Corticosteroids, they have delayed action, they are ineffective, they are not the first line drugs. Beta agonists are usually used in case of bronchospasm, and IM epinephrine may fail if there is a severe patient or severe reaction arriving late or a wrong dose or wrong site is administered, and if patient is using beta blockers. Now observation, there is actually no consensus regarding how long to observe and what, but in case of severe cases and thinking of biphasic reaction in patients, we are thinking that biphasic might be there we can admit patient for at least 24 hours or minimum of 12 hours. So biphasic is only there in 20%, a detailed history and workup is required. So this is very important. We have treated the patient, but patient has a chance of repeated action. So a proper information written plan should be given, which should be individualized, thinking of the biphasic reaction, the auto-injectors, pen trainers. Then food triggers. Food triggers is very important because some of the food items like milk and nuts, they can be hidden in any form. So it is not necessary they are mentioned on the labels. So in these particular patients, we should be very particular and we should be educating them that, especially when you go to airports or hotels, just please inform first about your food allergies. So we should look after the age groups, the newborns, elderlies, and pregnancy is the vulnerable age group. The comorbidities should be taken care. Medications, and most importantly cofactors, which we forget, because allergens, we might be allergic to many things, we might know, we might not know, but one day we might have the anaphylaxis with same allergen, because it might be an additional cofactors. It might be an exercise, food allergy induced exercise, or maybe an acute infection, stress, menstrual periods, or a dysregulation of your routine, alcohol, drugs. So we need to identify these cofactors so that these cofactors can be avoided in future. So this one important thing about EpiPen, it's not still available freely in India. The cost is around 15,000. We are very strongly waiting, but how useful this will be? Because two doses are there, 0.15 mg and 0.3 mg. So consider a 50 kg person, 0.3 mg auto injector will not be helpful for an obese patient of 60-70 kgs, which is in normal adult Indian weight. The length of this needle is very small. So what manipulative efforts we Indians have made is, you can keep a 1 ml syringe with a long IM needle of 2 cm into a spectacle case. So to avoid any light, and this person can carry this always with him and can be taught how to inject in case of any symptoms arrive. So a quick take home message, 7 A's, always administer adrenaline into anterolateral thigh in adequate doses, be agile in anaphylaxis. And these are 5 D's, don't delay diagnosis, doubt, better to treat, drugs are precedence, and it is DABCs, don't hesitate to give adrenaline, and don't discharge the patient without an action plan. So with this, I thank and definitely refer to an allergist as and when required, so that we can work upon this and plan additional treatment on immunotherapy and protect these further cases. So thank you so much. Thank you for your patient hearing. Sorry for being so quick.
Thank you, ma'am. Thank you very much for the wonderful insight. How frequently we can give adrenaline, and is there any maximum dose for adrenaline?
So usually they say 3 doses can be given, but as of there is no such recommendation. It is on the deciding on the patient, the physician ability, and usually we take 5 minutes. Every 5 to 7 minutes or 10 minutes we can repeat the doses.
What drugs and equipment should we have as a clinician in our OPD?
Yeah, I think adrenaline. I am also having adrenaline. एक दो लोगों को मैंने वेसोवेगल में भी लगाया है, because I have no choice. जब बच्चा गिर गया है तो we don't know, वहाँ पे clinic settings में we don't have that much of trained staff that you can think of कि ये anaphylaxis है या नहीं है, but it's better safe to give. Then I think an oxygen cylinder, an ambu bag, and then IV line. I think these are the things.
Sure. Thank you.
Any questions? Thank you so much.
Thank you very much. So we request the faculty and the panelists and the speaker to please proceed for the felicitation. Thank you, Dr. Tina. For the next talk, I'd like to invite
10 minutes time, and whatever is left, we'll do it in the next time. So we'll start with bedwetting. I think this is one of the topic which is very close to my heart. Reason being, we see a lot of children, especially I get most of the referrals from our pediatric fraternity only regarding bedwetting in children, especially those refractory cases who are still persisting after 10 years. So my first question, do you think bedwetting is treatable? Yes or no? Yes? Okay. So when you look at the prevalence, actually you will see that almost by 5 years, there will be only 15% of the children who are still wetting the bed. By 10 years, the number comes down to 5%, and by 15, only 1% of the children would be still wetting the bed. You have to still understand that by usually when the child is born, there is a spontaneous reflux, but by the time they become 5 years, they are usually dry by night, and by 3 to 4 years, they are dry by day. So we are expecting the child should be okay by more than 5 years of age. So there are two things which are very important for a child to have a socially acceptable voiding. One is adequate storage in the bladder, which means that uterus should be relaxing when the bladder is filled, and they should be contracting when the bladder is expulsing out. The sphincter should be competent, because if there is sphincter incompetence, then there can be dysfunctional voiding. There are multiple definitions of nocturnal enuresis or bedwetting. The most important definition that you all should remember was if there are more than 3 episodes, like 1 episode per month for more than 3 months, then and the age is more than or equal to 5 years, this is bedwetting. And if this child is coming to you, definitely you have to give him some treatment. So when you talk about bedwetting, I will just like to make you an approach of how to approach a child with bedwetting. Always a child coming to you, if the age is more than equal to 5 years, always take a history whether it is primary or secondary. So to differentiate whether it is primary or secondary, it is very important that if the child has been ever dry for more than 6 months period, then it is definitely secondary, because the child has been dry for 6 months. If the child has never been dry, then it is primary. Then the two things which are very important. So what is primary monosymptomatic nocturnal enuresis? These bedwetting children may have daytime symptoms like urgency, frequency, they can be heavy, all should know. If there are these red flag signs, then definitely it is non-monosymptomatic. So bedwetting purely is a monosymptomatic without any daytime symptoms. If daytime symptoms are there, then it is non-monosymptomatic. I am going to skip overactive bladder and dysfunctional voiding. There are various, the voiding disorder is a huge spectrum. You would actually see it starts with nocturnal enuresis or bedwetting, but then there can be overactive bladder, there can be dysfunctional, there can be lazy bladder. So everything you can pick up from in history. History is the most important part in any child with bedwetting, history and physical examination. Etiology of bedwetting. So why etiology is very important? Because you may use left and right anything available for treating bedwetting. But if you know what is causing bedwetting, you can actually give a targeted therapy like we do in cancer. We just target. So if there is a small bladder capacity, you can use drugs to increase the bladder capacity. If there is nocturia, you can actually use medicines to decrease nocturia. Then if there is OSA, obstructive sleep apnea, if you correct that, bedwetting will improve. Genetic predisposition is again very important. So any child who has one parent having bedwetting, there's almost 50% chances of having the child having bedwetting in future. So you can always tell the parents, don't scold the child, this may be related to your genetic issues. So now, I have always told you one thing which is very important is nocturia. So nocturia means there is failure of this ADH hormone or vasopressin production. Normally what happens whenever the child is like more than 5 years of age, vasopressin production at night increases, because of which there is decreased amount of urine production in any child. But supposing if this vasopressin is not produced at a normal amount, you will find these children will continue to wet the bed even at age more than 5 years of age. So this, how can you know whether it is nocturia or is it small bladder capacity? But before that, one thing which is very important, all these children who have bedwetting, they have lot of psychological issues, and it is very important to address that also. Especially you really need to counsel the parents who are very pissed off with this bedwetting problem. So I'll skip all this because this is all about, yes, and it is very important. A lot of children come to us who have autism, ADHD, who still continue to keep wetting the bed. So in this, the scenario, most important thing, whenever you take a history, please do take a history of their development, of how much the mother is having psychological issues, whether the child is still having any anatomical or psychological issues which is creating this problem. Sometimes you find the school has changed, there is some issues going on with the parents. So a lot of anxiety issues can cause this problem. Important history. So these key points are very important. Always differentiate primary or secondary. Since how long the child has started wetting bed, whether has ever been dry or not. Then always ask about frequency, how frequently. A lot of times you will find that children are having more than 2 episodes per night. Then daytime symptoms, urgency, frequency, hesitancy, wet undergarments. Very important thing, constipation. A lot of times it is unaddressed. These children may have constipation. We always advise you to do a rectal diameter once you do an ultrasound for kidney size. That would really give you an idea. Plus a Bristol stool chart can also help. Developmental history and history of diabetes. Sometimes even they may have diabetes, there may be polyuria, and the parents are still thinking that this is bedwetting. So now history, we have already discussed a lot of points in the history. So I will skip all these points because you can take investigations, just some basic investigations that we tell you to do is urine routine, HbA1c, a random blood sugar, and ultrasound KUB and KFT. That is more than enough. If you want, you can top up with a CBC. All this is very much enough for doing in a case of a child with bedwetting. Always do a physical examination. The genitalia should be examined, the back should be examined. You should see if there is any perineum, anything is there. Can I just continue for 2 more minutes? Okay. So this is again very important. So we have spoken about the history, we have spoken about the examination, then investigations. This is the key point of this whole talk, bladder diary. Because bedwetting patient cannot be treated without having a bladder diary. This diary we keep giving to every patient who come with a voiding dysfunction. It's very important. How do you tell them to make? So a lot of times you will find these bladder diaries, they will write half cup water, 1/4 cup water. Please ask them to take a measuring cup. Clearly write, we ask them to make it for minimum of 2 days, where we ask them just measure the amount of intake, what the child is taking, and output has to be measured and thrown away. If you really want nocturia to be documented, please tell them to do the urine output measurement for 2 nights. The mother may need to wake up. Once you have this, you can have a lot of things. So with this, you can rule out polyuria, you can rule out small bladder capacity, you can rule out nocturia with this. So this is what I have spoken already. You can, with the test, you will just come to know. Always treat the bowel dysfunction before you treat the bladder dysfunction. So constipation has to be strongly treated in these children and continued treatment. So urotherapy is one word, most important. You have to train the parents of how the child should empty the bladder. There should be a good amount of sleep that the child should have. They should not put a lot of pressure on the child about caffeinated drink. So before you talk about the drugs, there is one thing about the diet which is very important. Always ask them to take low salt diet during the evening and avoid taking lot of fried and oily foods during evening. Junk has to be completely avoided till the time you are treating. I will skip all this. I think I have spoken. So enuresis alarm. Enuresis alarm is not a normal alarm that we are talking about. This enuresis alarm actually is an alarm where it is put on the underpants of the child, and once there is a drop of water, it is similar to the rain alarm that we were using when we were doing our class 10th project. So whenever there is a drop of water comes, it starts buzzing. So this is the enuresis alarm. It has a 100% success rate, but it takes a lot of time. So the parents have to be really motivated to use this alarm because it is very, the initial voice or the alarm is very soft. So we have been using these drugs, oxybutyl and tolterodine during small bladder capacity. For desmopressin, if there is nocturia, it works. So there is a specific protocol. I would definitely not suggest using desmopressin without monitoring. You really need to monitor the sodium levels. Plus, it is very, very important that it has to be tapered off. You just cannot stop it after 3 months or 2 months. Any resistant cases, if you feel there is any renal issues involved in it, if there is recurrent UTIs, if there is structural defects, do refer them to a pediatric nephrologist. So, we have been using, I have been very, very closely doing this bedwetting. It was the first uterine session with IIP West Delhi that we had done in 2019. This bedwetting clinics we have been running so far. In India, it's almost 91 plus clinics that we have. And our bedwetting clinic at Akash started in 2017. This is some of the things that I have done to promote bedwetting treatment in children, which means a lot of voiding disorders. I think a lot of children have become okay. This is our transplant team. So miles to go before we stop. Thank you so much. You can always take the questions later.
One more thing about the alarms.
Yes, these are readily available. Actually, if you go and search, I can share the number. It's very cheap. So initially, when we were using these alarms, it was for almost 3,000, 4,000 rupees. But now this alarm is actually available for 900 rupees, and they porter, so they charge 1,000. But the only problem with this alarm is it is very soft. So initially the parents have to tune their ear to hear this alarm. But over a period of time they become expert. But it's available. It's very much available. And patients have been using it. Thank you.
Thank you, Dr. Thank you, Chairperson,
for this opportunity. So, I'm a pediatric ophthalmologist, and in ophthalmology itself, it is a very niche specialty. But most of the children who come to me have first asked their pediatricians, the parents have first asked the pediatricians for opinions, that they feel that the child is maybe not seeing well, having a squint, or some disorder, and they always want the pediatrician's opinion as to what they should do, where they should go, and what is the right time that the child should get treated. So I think pediatricians play a very big role in preventing a lifetime of visual disability in most of the children. So why is it important to treat the child very early? We all know that visual development occurs maximally in the first 2 years of life. The child starts fixating at about 2 months of age. The 3D vision or stereopsis starts about 5 years of age, and most of the development is done by the age of 2. Initially, the child's eyes may appear to wander, but later on they fixate well. And there are milestones such as, looking at the mother's face, the social smile, and fixation of the eyes, whether the child is able to walk around or crawl around without bumping into objects. These all give us a clue as to whether there is any visual disability. The warning signs, I think as a pediatrician that you would mostly note are tearing, redness, any obvious squints, photophobia where the child is closing the eyes in bright light, and of course leukocoria or the cat's eye reflex. So like I said, visual development occurs in the first few years of life, and why is it important to treat is because God has given us eyes up front so that we can use both the eyes together and have something called binocular single vision, which leads to stereopsis or 3D vision. But approximately 2 to 4% of children have amblyopia. Amblyopia or lazy eye is when one or both eyes is not seeing well, resulting in impaired development of vision at the level of the visual cortex. So some of the amblyopes can be easily recognized because you can see an obvious cross eye or a strabismus. But very often, if there is a refractive error or a power of glass, which is much more in one eye than the other, the child keeps seeing well from the better eye, and we do not diagnose a visual impairment in the other eye. So amblyopia needs to be treated early. We have a lot of treatments for it, which includes the patching or the occlusion therapy, where we occlude the better eye for a few hours every day. If the child is resistant to occlusion, then we do atropine penalization, where we blur that eye with atropine eye drops. And now we have AI-based therapy, which is called dioptic suppression, anti-suppression therapy, where we allow the suppressed eye to take over and try to become the dominant eye. So these are like video game based appliances. The challenges as a pediatric ophthalmologist is there is a low level of awareness on appropriate treatment in an early age, and so most of the diagnosis is delayed. And of course, when a 1-year-old, 2-year-old comes into the clinic, visual acuity assessment and other things can be challenging, but we do have a lot of pre-verbal visual assessment charts and other techniques that we use to objectively assess them. So why do we need to treat early? As we know, we have a beautiful SUV, but it is not going to start, it is not going to run, and you have to tug it along, there is no point. So if you have a cosmetically good eye, but if that eye is not seeing, it is not fulfilling its purpose. So the most common things that we see are refractive errors, which include myopia, hyperopia, and cylindrical powers or astigmatism. The prevalence of myopia is very, very high in school-going children, and it has been increasing by leaps and bounds. Treatment of refractive errors includes cycloplegic refraction, where we paralyze the muscles of accommodation and get the correct power of glasses, optical prescription of glasses. Some children may have corneal irregularities, which can be treated only with contact lenses, and glasses don't really help them. We have to screen for associated disorders and of course treat any associated amblyopia. So not just our country, but globally, we are on the verge of a myopia pandemic. By 2050, we estimate that half of the world's population will be myopic or have minus glass powers. And there's been tripling of myopia rates in children and teens over the last 3 decades. There are several causes. One is the increased near work. So we blame the smart devices that are handheld, but also near work, which includes excessive reading even from books, can induce myopia. Couple that with reduced outdoors, where we have stopped looking at infinity. So unless we look at infinity, the accommodation of the eye does not relax. Unless we go outdoors in the daylight, there is no looking at infinity, so it compounds the stimulus for the eyeball to grow. And of course, there is a genetic predilection as well. So quarantine myopia is what we saw during the COVID-19 pandemic, where the children were all doing online classes, they were not going outdoors. So we had myopia tripling, quadrupling during that period. So we're going to have a generation of children who are all going to be on glasses. So why do we need to worry? Myopia, okay, you give them minus glasses, they'll see well. But there's a lot of impairment in quality of life, healthcare burden, and there are complications of myopia where they can have retinal thinnings, retinal detachments, and other things. So what can we do? One is, of course, the lifestyle changes, a lot of outdoor activities. We do give low-dose atropine drops, 0.01%, nighttime, every day, every night. This halts myopia progression to a large extent. Then we have special myopia control glasses. They're called halt lenses and DIMS lenses, which cause peripheral defocus and prevent elongation of the eyeball. And for very high myopes, we have something called ortho-K lenses, which the child wears overnight. It reshapes the cornea, flattens the cornea, and prevents further progression of myopia. So all these are available. It is just we need to know what to do when. Then I just want to go through a few common pediatric ophthalmic disorders. When I think almost all of you would see is a nasolacrimal duct block, where the parents come to you that the child is tearing a lot. So the first thing that we do is a lacrimal sac massage and some topical antibiotics. Now once the nasolacrimal duct, the blockage is normally by a membrane. As the child grows and crosses the age of 6 months, it becomes osseous. Once it is osseous, then the massage doesn't work, then we do have to do a probing. If there is an acute dactyl cystitis, you have to treat with systemic antibiotics. We've seen children lose vision because of NLD blocks when they go into orbital cellulitis and compartment syndromes and the optic nerve damage. Just a few minutes more. Cataract, I think, is something that we all need to recognize. All of you, I'm sure, in the NICU are doing the red reflex. So if you do not see a good red reflex, or you see a white reflex or leukocoria, it could be a cataract, it could be a more ominous thing like the picture there, which is a retinoblastoma. So cataracts may be unilateral, bilateral, they may be total mature cataracts with white, reflexes both eyes, so they may just be lamellar cataracts. Now, lamellar cataracts can also cause severe distortion of vision and dense amblyopia. They all have to be treated surgically, and they need glasses and long-term amblyopia therapy. The lenses may be dislocated in cases like Marfan's, where again surgical treatments are warranted. ROP is a topic that I need not stress to this august audience. We all know when to screen them. But the thing is, treatment modalities have also changed. When we have aggressive ROPs, we even give anti-VEGF or vascular endothelial growth factor injections intravitreally. This has reduced the load of laser on the retina, thereby preserving peripheral vision. And of course, in advanced stages, we do need to give, we may need retinal surgeries. Almost all children who recover from ROP need myopic glasses. In squints, they may be very prominent, they may be convergent, divergent, vertical squints, or they may just be pseudo squints where you have large telecanthus, and as they grow, they just become normal. Squints can be treated with just glasses sometimes, or they may need treatment, but all of them need amblyopia therapy. The squints may be just horizontal squints or complex squints. Sometimes sudden onset squints with diplopia, like in this child, was because of an inflammatory orbital disease, which all she needed was systemic steroids. So again, ideal age for squint surgery, the treatment has to start when we detect first, and most children who have a constant squint ideally need surgery within the age of 1 so that they can develop sclerosis. Less commonly, we see these things like orbital dermoids, and retinoblastoma is one of the most catastrophic tumors that a child can have in the eye. So we had earlier, it was remove the globe life, but now we have moved to globe salvage, where we give chemoreduction and lasers, transpupillary thermotherapy and things like that. Now we have moved to vision salvage, where even central retinal tumors, we can do intraarterial chemotherapy and shrink them. It's not cured. Yes, I'm kind of done. It's just, again, trauma, and these are the things we see commonly in children, where, in Diwali, Holi, they come with chemical injuries. We can treat them with amniotic membrane grafts, and sometimes we have to do multiple procedures in children to tackle multiple disorders. Thank you so much.
Just one thing, we have treatment of myopia, say progression of myopia.
Yes.
Can we use nobody apart from glasses?
You could, sir, but we will have to document every time if the child is progressing. But there's no harm in giving atropine 0.01%.
How long?
We can give, so it is recommended that if the child has a progressive myopia, that is when we started, we can start it as early as 4-5 years of age, and atropine drops work till about 12-13 years of age. Beyond that, it doesn't. You can continue till then.
No side effects?
No.
But it helps in reduction.
It helps to prevent progression. It cannot reverse the myopia that is already there. But in spite of that, if it is progressing, then we may need other modalities. Thank you, sir.
How many gifts do you have?
I was a good person. Let's take out. So we have reason to wait. Okay. Dr. Dinesh Goyal. Is he there? Next, please. Dr. Kiran Agrawal. वो भी नहीं है.
कितनी खुशी हो रही है लोगों को ये सुन के.
जो है उनको दे दो. डॉक्टर पंकज गोयल. वो भी नहीं है. चलिए. उधर का उधर. ओके. डॉक्टर
सिद्रानूर वो भी नहीं चलेगी.
सिद्रानूर तो थी यहाँ पे.
चलेगी.
थी ना थी.
थी मतलब
अपने आप में मेरे थी. ये सब लोग थे. सब वो थे हो गए.
डॉक्टर विवेक आर्या.
वो भी थे.
तो अब हम 2 लोगों पे आ रहे हैं. डॉक्टर प्रशांत सेठ चले गए.
यार इनको इन्फॉर्म कर देना इनका
सुनील बेंजीरता सर नॉट देयर.
नहीं इन्फॉर्म तो कर देना पता निकले सीट.
डॉक्टर केडी गुप्ता.
यार जो बैठे हैं वहाँ से निकाल लो.
डॉक्टर नेहा भंडारी. शी इज हियर वेरी मच हियर. So congratulations.
नहीं ये आई अभी है बोगी. तो सवेरे से आया उनका होना चाहिए.
यही रहे मैम. सर आप आगे डॉक्टर विवेक आर्या को भी इसका है नहीं अभी इसमें डाल.
सर एंट्री बंद हो चुकी है.
तो थोड़ा हिला लेना पड़ेगा. ये लो. तीन निकालो. That has woken people up. और मैं एक और निकाल दूँ
क्या दूसरा भंडारी भाई भंडार भरे
मैं वहाँ भी
Look here. Wait. Just hold on.
Yeah.
अब आगे मत
Yes.
जाना.
Now look here.
क्या? मैं कह रहा हूँ आगे मत चले जाना. क्या हो गया उड़ गया तो.
Wait, once more. Nice, thank you.
डॉक्टर रश्मि जोशी.
भाई साहब थोड़ा सा ध्यान रखो यार.
आधा पार्ट में नहीं ना. डॉक्टर स्मिता रामचंद्रन. ऑर्गेनाइजिंग कमेटी ने नहीं इसमें पार्टिसिपेट किया. फिर मेरा भी ले लो.
इस बैटरी मांगना सोनी.
डॉक्टर एसी मिश्रा.
ओवर ही चार्जिंग निकाले उसमें एक पड़ी.
डॉक्टर एके मनोज.
डिस्चार्ज.
डॉक्टर मंजू गोस्वामी. डॉक्टर विद्या नायर अभी भी गई है. डॉक्टर हर्ष गुप्ता.
ऑर्गेनाइजर में से कोई निकालता है सिर्फ मेगा लड़की ड्रॉ में है. ऑर्गेनाइजर में कोई इधर उधर है तो हो रहा है. अदरवाइज ऑर्गेनाइजर नहीं है तो बाहर है तो अपन करेंगे.
जो समझित का वही सही है.
जो हॉल वाले हैं
डॉक्टर टीना गोयल.
वेल डिजर्विंग खुश की टाइप.
डबल तालियां.
सेक्रेटरी इलेक्ट. एक और इनाम दिया जाए इसको सेक्रेटरी रैंक से नवाजा जाए.
I can take the color of your choice.
Doctor choice. Yes, now look here. Ma'am, please smile. Just wait once more. Yes. Smile. Just wait. Ma'am, look here. Hold on.
छोड़.
Yes. Thank you.
अल्लाह के दे.
Nice. Thank you. Done.
भैया जी घर को जाए कहाँ. भाई.
Just wait. Look here, smile. Hold on. Nice. Thank you.
Dr. Ramaswamy.
I'm feeling at home here among you pediatricians because I started my career as a pediatrician. So 25 years back, I did TCH from MAMC and then I turned into a gynecologist. So this is very special. In fact, thank you for giving me this opportunity. And we are talking about a very special topic today, which is another very important thing which requires a lot of collaboration between pediatricians and gynecologists, PCOS. So let's see. So as we know that PCOS is very common. According to ICMR data, 1 in 5 adolescent Indian girls show features of PCOS, but only fraction are recognized early. Menstrual irregularity, acne, weight gain, which are common during pubertal transition, are also early whispers of PCOS before the full-blown syndrome appears, affecting her metabolic and reproductive health. So what are the early clues? They can be clinical, metabolic or psychosocial. So clinical clues are generally irregular periods, persistent acne despite local treatment, moderate to severe hirsutism, weight gain. Metabolic can be features of insulin resistance, acanthosis nigricans, elevated lipids, and psychosocial can be body image issues, depression and anxiety. But they can lead to some serious long-term implications. Some reproductive sequelae, some metabolic sequelae and some psychological sequelae. So they can be infertility, poor pregnancy outcomes, endometrial hyperplasia, cancer, type 2 diabetes, metabolic syndrome, obesity, hypertension, cardiovascular diseases, non-alcoholic fatty liver disease, obstructive sleep apnea, eating disorders, depression, anxiety and overall a poor quality of life. So we need to do something. But the good thing is PCOS is not a disease of adulthood. It's a story which begins in adolescence. And as pediatricians, you hold the pen for the first few chapters. So when we recognize the early clues, we can preserve her fertility, and her future health. So let's rewrite the PCOS story from a delayed diagnosis leading to reproductive and metabolic sequelae to timely diagnosis and timely intervention to early empowerment. So how do we diagnose PCOS in adolescents? Now, in 2023, we have clear-cut international evidence-based guidelines to diagnose PCOS. We need two things. One is we need persistent oligo or anovulation, and second thing is we need hyperandrogenism. Now this can be clinical or biochemical, and of course we have to rule out conditions which mimic PCOS. So we need two things, oligo or anovulation and hyperandrogenism. After ruling out, it's a diagnosis of exclusion because it's a lifelong label, so we have to rule out the things which present in a similar way right at the outset. So they can be congenital adrenal hyperplasia, hypothyroidism, hyperprolactinemia, androgen-producing tumors, Cushing's syndrome. So how do we diagnose anovulation, ovulatory dysfunction? So first, here post-menarche, any pattern of menstrual pattern is normal. It's okay if they are irregular or any pattern is alright. But after the first year following menarche, up to 3 years, cycles which are shorter than 21 days or longer than 45 days are abnormal. 1. 3 years post menarche, the criteria is going to change slightly. So cycles shorter than 21 days or longer than 35 days are going to be abnormal. And any time 1 year after menarche, any cycle which is longer than 90 days is any time abnormal. Or if there are no periods by 15 years of age or 3 years post breast development, then also it's abnormal. So all this will contribute to ovulatory dysfunction. So when generally they present to you, adolescent girls are going to present to you with, or the mothers will come bring their children and say that the girl is having irregular periods. So now you know there are well-defined criteria to say it's normal or abnormal. So whenever this kind of a pattern is present, we have to consider a diagnosis of PCOS. So we start looking for the second feature, which is the androgenism, hyperandrogenism. So clinical hyperandrogenism, we need of course a complete history and physical examination, and we use the modified Ferryman-Galway score. A score of 4 to 6 should be used for diagnosis of hirsutism, where we take 9 body areas, score 9 body areas: upper lip, chin, chest, upper abdomen, lower abdomen, arms, legs, upper back and lower back, and count the score. We take only terminal hair which are there in a male-like distribution, more than 5 mm in length, and they should be pigmented. So if the score is more than 4 to 6, of course the score is going to vary according to the ethnicity, but that should be classified as hirsutism, and that's enough for hyperandrogenism. There is no universally accepted visual instrument for assessing the presence of acne. Then apart from looking for hirsutism, we also do the rest of the clinical examination. We note the height, weight, the BMI, the blood pressure, look for features of hyperinsulinemia, which can be acanthosis nigricans, skin tags. We look for acne, hirsutism grading, and we also do a genital examination to rule out a clitonomegaly. Now, when do we do a test for biochemical hyperandrogenism? So, if there is only menstrual irregularity and clinically there is no feature of androgen excess, in those circumstances we have to do a blood test to look for biochemical hyperandrogenism. And when we find only one feature, we can label them as at risk for PCOS. We can't really label them as PCOS, but then we can say they are at risk for developing PCOS and we can follow them longitudinally. Can I take some more time? Okay. So the investigations which we should order whenever we see this kind of a clinical picture are total and free testosterone, DHEAs, which will tell us about the androgen source of adrenal source of androgen, 17-hydroxyprogesterone to rule out CAH, serum cortisol HAM, that's to look for Cushing's, TSH, a prolactin, and also there is a metabolic component to PCOS, so we have to do at the diagnosis a lipid profile and a 75 gram 2-hour GTT to diagnose impaired glucose tolerance or diabetes. So do we need the ultrasound to diagnose PCOS in adolescents? No. So adults we use ultrasound to diagnose PCOS, but in adolescents we don't need the ultrasound. Do we need serum AMH levels to diagnose PCOS? It can be used as an alternative to ultrasound in adults but not for adolescents. So AMH and ultrasound is not for adolescents. We just need two criteria.
What is AMH?
AMH is anti-Müllerian hormone. It's produced by the granulosa cells. It tells us about the egg count. So it is raised in PCOS. So now when we talk about interventions, lifestyle management is the core focus in PCOS management. Healthy lifestyle behaviors, and they need ongoing assessment and support to improve, optimize the general health, quality of life, body composition, weight management. They need a lot of behavioral strategies. They need dietary intervention. So it is very clear we have now we have ChatGPT, Google, and everybody is giving advice on PCOS because it's so common and everybody is looking for advice on social media and on internet. So it's important to tell to your patients there is no evidence to support any one particular of diet composition over the other. Any diet composition which is consistent with healthy eating will have health benefits. It has to be sustainable and it has to be tailored to the individual preferences and goals. It has to be flexible, it should not be unduly restrictive, and the value of broader family engagement has to be considered. And involving a nutritionist definitely helps. Exercise, again there is lack of evidence supporting any particular type of or intensity of exercise being better than another, but adolescents should aim for at least 1 hour of moderate to vigorous physical activity per day, and that focuses on strength training, muscle and bone strength at least 3 times a week. So when we talk about pharmacological principles to treat PCOS, it has to be a shared decision making because it's a young child and parents are concerned about the long-term well-being, and so individual characteristics, preferences, values, everything varies a lot. So understand how these individual adolescents value treatment outcomes is very important. So the first line therapy for menstrual irregularity and hyperandrogenism is OC pills. Now, no particular type of OC pill is favored, but 4th generation one, 3rd and 4th generation which have progestins which have anti-androgen component properties are better. Again it's a shared decision making. We use the smallest possible dose. What is the role of metformin? So a lot of, I don't know if you see patients with PCOS come to your clinics. they are already taking metformin many times. So metformin alone can be considered in adolescents who have metabolic risk factors like impaired glucose tolerance or abnormal lipid profile. So or where OC pills are contraindicated, not accepted, not tolerated, and you need something to regulate the menstrual cycles. But again, shared decision making, they have some GI side effects. We start with a low dose and build up to gradually build up. What about the combination metformin and OC pills? They have been beneficial in children or adolescents who have again high metabolic risk, like high BMI or impaired glucose tolerance. Inositol has been investigated recently to in place of metformin, because the moment you prescribe metformin, they think, no, I don't have diabetes, why are you giving me this drug? So they think if you start taking metformin, they're going to become dependent on it and they'll have to take it lifelong. So this is an alternative which has come up. So according to individual preferences, it can be opted for. But again, we need more research and good quality data on this. In case hirsutism is not responding to OC pills after 6 months of therapy and cosmetic therapy has not worked, then we can go for anti-androgen drugs. Or if there is a contraindication to OCP therapy, or it's not tolerated well, spironolactone is generally has low risk of side effects. Mechanical laser and light therapies have been used and they are quite safe. So these adolescents have a lot of depression and anxiety, body image issues, so they should also be dealt with accordingly. So they may need some psychological therapy, some cognitive behavioral therapy. So just to the take-home messages should be, when we make a diagnosis of PCOS in adolescents, we have to be conservative. At the same time, we should not miss the diagnosis. So we need both ovulatory dysfunction and hyperandrogenism, clinical or biochemical, to diagnose PCOS. But only if one feature is present, we label them at risk for PCOS and follow them longitudinally. We don't leave them as such. Don't use pelvic ultrasound routinely in adolescents. Lifestyle modification is the first line. It has to be family-based, realistic weight goals, physical activity, sleep hygiene, limit sugar-sweetened beverages. So this improves both metabolic and menstrual outcomes, and it is foundational. Among pharmacotherapy, OC pills are the first line for symptom control. Metformin can be added for metabolic indications. It is important to screen for cardiometabolic risk factors at baseline and periodically thereafter. So blood pressure, lipid profile, OGTT has to be done at diagnosis. Also, we need to address mental health early. And at the end of it, it's all shared decision making, individualized care, involve the adolescent and the family, discuss, counsel about contraception, and plan transition to adult services. So the earlier we act, the easier the journey. So let's catch PCOS before it catches our future. So if every pediatrician is empowered to diagnose PCOS early, we won't need to treat its complications later. Thank you.
Any questions from the audience?
How long we continue OCPs? How long?
So there is no defined duration, but we have to reassess the treatment according to the response. So like we can continue very long term also. But initially for a year.
No, the adolescent is taking, and then how long will you continue? She has to go for a marriage and then pregnancy. So you stop. What will you do?
So treatment is symptom based. So when she gets married, she needs treatment for fertility. So based on what her needs currently, she needs contraception. If she's having hirsutism, if she's just having abnormal periods,
You have to give a break in between.
no, we can give it in continuity. After 1 year, we can give a break of some time, but we can give it in continuity. There's no harm.
Dr. Monica, isn't it related to, you said androgen? If we do test and once it's come down, can we stop the OCP?
No, but again, the basic pathology is the LH production is higher. So that is going to be there. It has a genetic link. Something to do with the gene. So it's going to be there. It's going to come back. So unless she maintains a healthy lifestyle, maintains her optimum body weight and exercises on a regular basis, yes. So it's a spectrum and the severity can vary from time to time. So if it is mild, the symptoms may not be apparent at all. If they put on weight, leave exercises and everything, it becomes moderate to severe, they begin to show symptoms. The moment they lose weight and adopt a healthy lifestyle, again they go into the mild spectrum and then they have no symptoms. They're getting regular periods. The acne, hirsutism is not such a problem, so she's happy, she doesn't need medications. So it is like a car which is not moving on its own. You dhakka do aap thoda chalegi and you don't know kitni din tak chalegi. There's no defined this thing.
And risk of infertility in this patient despite treatment?
Despite treatment, yes, it's high, but it is amenable to treatment. It is very easy to treat. One of the easiest conditions to treat when they have infertility. They just need a little bit of help, but they're easier to treat vis-a-vis other conditions which lead to infertility. Yeah, but it may be associated with other conditions as well, like it's a hyperestrogenic state. So it may be associated with endometriosis, fibroids in the long run. Yeah, if they continue to be hyperestrogenic, they don't do anything with their lifestyle, then they develop other conditions also. Yeah, so that adds on to the problem.
Thank you so much for such elaborative discussion. Thank you so much.
Thank you.
Thank you. Chairpersons and the speaker.
डॉक्टर
डॉक्टर गुलाटी सर आप आ जाइए. देखिए ये we are enjoying that you stay here. Please come.
अरे सर एक फोटो लेना आप हमारी ऐसा लगे आप भरा हुआ था पूरा भरे
Yes, start. So we'll go very rapidly. The topic is how to recognize sick children at clinic and refer them early to PICU and do not miss it. So we have experts with us managing PICUs in and around Dwarka. So Dr. Vikram at Cloud9, Dr. Sameer at Akash Hospital, Dr. Manoj को सब लोग जानते हैं, and Dr. Yogesh at Max Dwarka. Okay, so objectives we just skip it. No financial advantage, as you know, PICU को कोई पैसा देता नहीं है. So we go forward. So diagnostic approach, most important is history, then examination, very minimal test, and then comes the molecular. But it's going other way around. Now many people are focusing on tests and rather than on history and examination. And we should be careful that a lot of new tests are coming and we do not know what to do with that. I'll briefly cover respiratory shock, we'll skip the infections. So the most commonest tool for hypoxia, I think everybody knows, is a pulse oximeter. Without that, we could not have survived COVID. Everybody was just managing with the pulse oximeter. Now over to Vikram. If you do not have a pulse oximeter, then at clinic, what are the signs do you look for to say it is respiratory failure?
It's very simple. Proper assessment with the key. For so many years we've been learning about PAS assessment. Going to follow the PAS assessment triangle, followed by initial assessment, secondary assessment, we are not going to miss any patient. We all are intense patients. We have n number of tools in our pediatric, but we still follow normal PAS assessment. With that, they are not going to miss anything. So whenever we in PAS assessment we come to airway breathing and circulation. So depending on that we define respiratory distress is there, respiratory failure is there. If there is a accessory muscle used with tachypnea, that is respiratory distress. If there is a accessory muscle used with tachypnea with central cyanosis or peripheral cyanosis, that is respiratory failure. If the sensorium is going down, that is respiratory failure. If the patient has some associated shock, that could be also a sign of respiratory failure. So it's very simple. Based on just clinical assessment, you can easily distinguish between distress and failure. Do not need even any pulse of that.
But if you do have a pulse oximeter, use it. But these are the signs you should never miss for. A decreased mental status is very important. Now we have so many sounds in our respiratory tract. Sameer, which is the sound you are most afraid of? A stridor, a wheeze, or a rattle, or a grunt?
Grunting, because it is patient is trying to maintain his own beat. So that is the patient is already going into failure. That is the most dreaded sign that we have in kids.
And the second most sign that you are afraid of, other than grunting?
Stridor.
Stridor. So we are afraid of these two sounds.
A sound which starts on inspiration, we are afraid that is stridor, and the sound which is happening in expiration current, we are afraid of these two sounds. So among the respiratory assessment, to call it failure, Yogesh, what is the most important criteria? Is it the saturation or is it the sensorium?
Again, the basic remains same. That is the primary assessment triangle. Like the appearance of the kid is the key actually. If the sensorium is going down, then it is indicating that the kid is going into the respiratory failure.
So if the sensorium is gone, we say it is respiratory failure, irrespective of saturation. Okay, very good. So there is one more point. What is the cutoff to define hypoxemia, Yogesh? You take it as 90 in your clinic, 92 or 94?
Usually for the small kids like the neonates, we take it 90%, and if it is bigger kids, we usually take it to 94%.
And suppose जैसे bronchiolitis है, उसका 92 है, asthma है, उसका 93 है. Maybe upon the disease it changes. Yes. The guidelines change as per disease also. Yes. But PALS क्या कहता है? What does PALS say?
94%.
PALS, keep it simple. They say anything below 94 is respiratory failure. So this is how we are trying to show you how a respiratory failure should be diagnosed. It's important is to have a low sensorium with or without hypoxia. So we have already discussed this. These are the type of pulse oximeter probes you should know for an adult, for a child, how it looks like, and you should follow them. These are the wrong readings that you get in the pulse oximeter. Be aware that the plethysmograph should be clear. Now over to Vikram. This is a child who has fast breathing, has nasal clearing, lower chest indrawing, but the saturation is 95%. Would you give oxygen hood or would you give HFNC?
So this is telling the patient has tachypnea, some accessory muscle use, and there is also subcostal retraction.
But saturation is 95.
It is telling it is respiratory distress. So when it is respiratory distress, I need to further find out the finding. So if there is a rhonchi and all those things, maybe some nebulization will decrease all this respiratory distress. But if there is a crepitation or if there is raise, it is telling me it is parenchymal disease. So in that scenario, I need to give some respiratory support to alveolar equipment. So that is the reason. Oxygen is not the purpose. Oxygen is a drug. Use it wisely. Whenever we are using oxygen, we have some target. So we always try to keep it more than 95%. But that more than 94%, it is not necessary that will come with oxygen. That can also easily come with alveolar equipment by using either HFNC, CPAP or non-invasive ventilation.
Correct. And the important take-home point is this oxygen that you give through oxygen hood is a cold oxygen and it's a dry oxygen which will cause more bronchospasm. So giving oxygen just like that through oxygen hood just to relieve the distress is obsolete thinking. We should definitely go for HFNC or some amount of CPAP. You will help the person in taking his breath. That is how we have changed our practice. Early referral, early putting the patient to HFNC.
Nowadays we are also saying whenever the patient we putting on HFNC, most of the time we are just giving air only. Sometimes we just keep them on 20%, 1%. He was admitted because of distress. His saturation was less than 90%. So initially we had to give him some oxygen. After the alveolar equipment, we are just giving 21% oxygen, and rest with the HFNC of 10-20 liter he is maintaining his saturation. So this is how we are able to taper our HFNC very fast, even tapering. Yes, because body is trying to maintain.
Body is trying to maintain by hyperventilation. Body is trying to do it, but that does not mean the child does not have workout breathing. To relieve the workout breathing, you have to give external respiratory support. Giving cold, dry oxygen will further make the disease more bad. So, Sameer, if you are given a choice of HFNC versus a CPAP in your PICU, you have a happy dog over here and you have a space room. Which one do you like? HFNC versus CPAP in your pediatric ICU?
So for the smaller kids, we prefer HFNC in our ICUs, and basically it gives a continuous flow. And for the pressure where there is any alveolar equipment is required, then we prefer giving pressure to the patient.
And what does the child like? Child likes CPAP or the child likes HFNC?
So HFNC is more tolerable to the patients because of the continuous flow and the easyability of the machine to be used.
Correct. So we have decreased our oxygen units in our ICUs by following this oxygen stewardship. We do not give unnecessary oxygen. Now to Yogesh. So is this a standard format in your pediatric emergency, and do you use it every day?
The pediatric patient, we have this kind of format, sir. Then starting with the initial assessment, the parent breathing circulation, and then the primary assessment, ABCD. We usually do it and they categorize. And
is there any advantage of using this?
It is a uniform thing, sir, so the uniformity remains the same.
So it does not matter whether Yogesh and Maninder is there, we will follow the same form, our diagnosis will be similar, our intervention will be similar, because we are following a set protocol.
Yes.
Thank you for that. So we have this respiratory distress, so blow by oxygen is important and how to do suction is very important. So do not separate the mother from a child in mild respiratory distress. We'll skip very fast. Vinamra, can you tell me, how do you localize in your clinical practice whether the distress is due to a lung or due to heart or what cause?
So it's very basic, all of us know. Stridor is a very prominent sign when we are dealing with upper airway obstruction. Retractions are prominent with upper airway obstruction, and it's usually suprasternal retraction which we see in upper airway disease, whereas in lower airway disease, wheeze is predominant symptom, and also you may have intercostal subcostal retractions depending on the severity. For parenchymal disease, grunting is a sign which is important, as well as for cardiac disease, and retractions are usually subcostal, intercostal with both parenchymal and cardiac disease. Hepatomegaly again may be pointed towards cardiac, though it may be pushed down even in cases of airway disease and lung disease. But it's again a marker of cardiac. We should be
so be very careful. We should not miss a myocarditis in an infant. And this is how the stridor is common in croup, wheeze in asthma, and grunt can be due to any of the following. So let us do a few case studies. A 1-year-old child has come with barking cough and has inspiratory stridor at rest. Just focus on only these 2 points. Vikram, what would be the diagnosis? Barking cough, stridor at rest.
Viral chorea followed by stridor, it seems like it's
Croup. So if you say this croup, stridor at rest, that means on sleeping also stridor is there. Will you admit or send home?
This is significant edema is there, so definitely I need to observe in either in emergency or admit, depending on the after treatment how it does. So initially we need to give adrenaline nebulization, and after that we can always after observing the patient for at least 2 to 3 hours in emergency, if the stridor is not
So what is the dose of neb adrenaline that you give in your emergency? It's a very high dose or you follow a low dose protocol?
Normal. In my practice I use undiluted adrenaline, which is 3 to 4 ml irrespective of weight and age, and it has been doing wonder for the child.
So the maximum dose is 5 ml undiluted. So Sameer, do you follow protocol like 0.1 ml per kg or 0.5 ml per kg?
We follow in a 0.5 ml per kg.
So higher dose. Yogesh? 0.5 ml per kg. And Vinamra? Okay, we follow 0.1 ml per kg. So there is a low dose adrenaline also you can give, but the maximum dose that you can give undiluted is fine. It is unit based, but what is written in guidelines is 0.5 ml per kg. There is no advantage or disadvantage. Other than this, when will you give dexamethasone? In this patient, will you give oral or IV?
So any form of steroid will help this child, depending on the clinical state of the patient. If it is mild stridor, we can only go with the nebulized Budocort. If the patient is having persistent stridor which is not improving after your nebulization, yes, we need to give some parental form of steroids. It can be either oral or either
So we have a croup child, he is 10 kgs. So how much steroid? It's written 0.6 mg per kg. So would you give 6 mg?
So most of the time I have been using is 0.15 because there are literature which is telling us comparing the 2 doses, and even the low dose is equally efficacious than 0.6 mg. Most of the time I use low dose.
And Vinamra, you use 6 mg in a 10 kg child?
We are giving scat dose 0.6 mg per kg.
Yogesh? 6. Sameer? Okay, so there are again 2 school of thoughts, 0.15 mg per kg per dose QID or 0.6 mg stat. What is written in textbook is 0.6 mg stat, but we can give 0.15 mg per kg per dose QID. Both are equally right. Maximum dose is 10 mg. Bronchitis is a disease which happens in kids only, so we will not discuss about a 20 kg child. So it's a disease of 5 years and 5 years.
Stridor we are using steroids.
This is croup. We are talking about croup.
Not in bronchiolitis. In bronchiolitis we are not.
We are not discussing bronchiolitis. In croup. 10 mg. 10 mg. Asthmatic child has come into your emergency. This is for Sameer. these are the treatments that you would give. My question to you is, ABG necessary in every sick asthma?
So not every patient will be requiring an ABG. Those who are on a sick side, having requirement of respiratory support, there we need to use it.
Suppose I have a ABG which has a CO2 which is normal. Is it normal or delayed asthma? Delayed presentation of acute severe asthma?
So it can be a delayed form because initially there is a CO2 washout, then the normal is a delayed form.
Correct. So having a normal CO2 in asthma is already a late sign. Because the child is hyperventilating, the CO2 should actually be low. If the CO2 is normal, that is mean 35 also, it's a late sign. Early sign would be CO2 would be around 30. So make sure when you have a normal CO2 in asthma, that's already a late presentation. The child had a severe asthma. So now Samir, which one do you like? You love this or that? I'll not say.
My wife said.
And in the screen you have to choose one. So you choose salbutamol or you choose levosalbutamol.
So both are almost the same.
No. My question is, which one will you use? I am not saying which is
levosalbutamol.
Salbutamol is equally.
No. I am asking which one are you using? Salbutamol? Very nice.
इसका फोटो से कोई रिश्ता है सवाल का?
फोटो से रिश्ता है? अभी क्या योगेश, which one? Levosalbutamol. Vikram? Levo. So they all are except Vinamra.
This is
Traditional. So I'll just tell you why. All guidelines always say salbutamol. No guideline ever says levosalbutamol. You quote anywhere anything in literature. But every one of us practice levosalbutamol. May I ask why?
हाउस का वर्डिक्ट है सबने वर्डिक्ट दिया
Why?
जज गई
Why all the guidelines? It's a marketing gimmick which is done by the company, gone to every pediatrician saying इससे tachycardia होगा, anxiety होगी, and then we follow it. And seniors बोला, juniors ने blindly follow किया, and now it's in our DNA. It's very difficult to change. So you have to understand that both are same. गंगाधरी शक्तिमान है. Levosalbutamol has salbutamol. Just don't believe in the looks. Okay, we'll go fast over here. NEB or MDI in asthma. Sameer?
Both are equally effective depending on the patient's.
In your emergency, would you give a MDI or a nebulization? Nebulization. All agree nebulization? Okay, we'll go forward.
In OPD, if the patient is tachypneic and having clear-cut sign of asthma, you can still go with MDI.
No, I'm not saying what you can.
I'm talking about clinical practice. Over in OPD, if you have this thing, you can give 2 puff every 5 minutes. And most of the time, they get
But
fine.
MDI has a better
deliverability. I know. My question is very simple. What do you do? I'm not asking what is written in your books. I'm saying what do you do, Vikram?
Sir, in OPD, I'm using MDI. When the patient is dropping in emergency, I'm going to oxygen-based nebulization.
I give nebulization, whatever the books might say. Okay, now the second thing is in hydrocortisone. Yogesh, which one do you like? You like hydrocort, methylpred or dexa as a steroid in asthma? You are expensive doctor. Methylpred is an expensive drug. Vinamra, methylpred. Yeah, very corporate doctors, very expensive doctors.
Most of the time I'm using oral prednisone. Most of the time oral prednisone.
So WHO and all other guidelines say hydrocortisone because it's easily available and it's the cheapest and it is equally efficacious. Only thing, side effects of methylprednisolone is less. That's why they are all saying methylprednisolone. Otherwise, hydrocortisone is equally efficacious.
Even the dose is less. As per GINA guideline, the dose is just 200 milligram per day.
Maximum dose you can give, maximum is 300 mg per day. So 4 mg per kg per dose, maximum of 300 mg per day. Now magnesium sulfate start giving in your emergencies. I go fast. This is for Vinamra. Now this is a child with bronchiolitis, has a saturation of 88%. You have given nebulization, hydration. There is heart rate 180, has crackles and wheeze, he is not improving. What would you think with this X-ray?
As the patient has not shown any improvement and the tachycardia is out of proportion, so we should consider, and there is also cardiomegaly, so we should consider cardiac.
It's very frequently missed. Children are referred to ICU, referred as bronchiolitis, they come out to be myocarditis. So 1-year-old child, this is for Vikram, has acute breathlessness, no fever, there is no stridor, no wheeze, no crackles, lung is clear. But there is a lot of tachypnea and you see a mass in the chest X-ray. So first is to the audience, what is the diagnosis? We have a X-ray which is showing opacity here, and we have a breathlessness, respiratory rate is 65, and there are no lung signs. Perfect. We have a winner over here. So Vikram?
So do not jump to an X-ray finding. Always go for PAL assessment. So in PAL assessment there is a D. D is for disability and dextrose. So if you are thinking that there is no adventitious sign, the tachypnea can be because of metabolic acidosis. If you check the D, there will be high dextrose. You do a gas, there will be metabolic acidosis, and immediately you will come to diagnose DKA. Then you will be going back to the same X-ray, and then you will be calling it, this is a sale sign.
So you can call it a sale sign only once you have another diagnosis. So remember, the metabolic causes causing effortless tachypnea is very, very important, because many people then diagnose this as bronchiolitis and start IV, BNS and refer. The dextrose will shoot up, it will cause more problems. Now this is, I just go very fast for Samir. A child who is having fast breathing, not feeding well, saturation 94, is it respiratory distress or failure? One line answer.
Failure, sir.
Why do you say it's failure? Saturation is 94.
CNS isn't getting involved.
Not feeding well. You have to recognize this. So we know it's respiratory failure. You give a trial and then be prepared for intubation. Now these are the high flow and low flow devices. You should be aware of them, because in respiratory failure you use a high flow device, and HFNC is one of them. So this is to Yogesh. These are your humidifiers in your emergencies or your clinics. Do you put water in them?
No sir, we do not use water for the humidification at point source.
You don't use it. Why? Because I've been using it for the last so many years.
Yeah, we are using it like this only without water, because it will increase the risk of infection and contamination.
So that is one of the reasons. Other reason is the oxygen which is coming from here is a cold oxygen. Cold oxygen passing through a cold water will never get humidified. It is just दिल को खुश कर रहे हैं, कोई होगा नहीं effect. So anything beyond neonates using this practice is obsolete. So when you have prolonged humidification required, you can use either of these machines which are easily available. Humidification of oxygen through a water which is not heated is impossible. So these are the respiratory supports you should.
Whichever it will.
No, which one are you? You choose one word. Normal saline. Vikram?
Normal saline.
So all the guidelines now say Ringer lactate, which is a cheaper and a better fluid. But still all the intensivists are saying normal saline. May I ask why?
Hyperchloremic.
So I know why normal saline should not be used, because it has high chloride content which will destroy the kidney. But still you are using normal saline. Why? Once you know Ringer lactate is better. The reason is one only, habit. Normal saline is there. Nurse knows normal saline. My order is clear, normal saline. So by habit we give it. That's the major problem. We are not ready to change. In maintenance fluid, Samir, which one will you use?
Maintenance fluid, half DNS, DNS, half DNS.
Whenever?
It's less than half DNS.
Okay, perfect. So we do not use isolate B. Last case, Yogesh, a child who has septic shock, who has a CFT of 2 seconds, pulses are bounding. What do you think this is?
It's a basically the pulse pressure is wide, CFT is brisk, and it is warm shock. Basically the kid is in the warm shock.
Okay, then intervene. You will say it's a warm shock, intervene.
Yes, knee pain also there. Basically the septic knee swelling or the cellulitis is also there, sir. So we will start some fluid for her initially.
Something, I want a clear answer.
Actually sir, first we will start on the bolus, sir, because they will need some bolus from here. And early non-epinephrine will be done here, sir.
So you want to start epinephrine in your clinic?
No sir.
We don't have epinephrine in your clinic.
We will need some bolus, antibiotic in the first hour at the presentation, and then we will proceed accordingly.
Okay, so we have to follow all this. Get a blood.
35 दे बाबू
I'll take a photo.
जल्दी हम लोग खड़े हैं मैं छोड़ दो उसको भाई छोड़ दो उसको जब बता ही छोड़ दो
फोटो यार वो देख
उसकी रिस्पांसिबिलिटी है ना
Like this?
अगला भाई वो कर रहा है यार अपना काम वो
Yes, look here.
Just कीजिए चल
Alright.
hold on sir hold on here वेट करेंगे तो
सर साथ में देंगे सर आगे आइए ठीक है यहाँ देखिए
अरे रुको मैं भी आ रहा हूँ। पिटारे में बहुत माल है।
मैम आ जाओ। अब some people are waiting for the draws.
अरे मैडम आप होस्ट ही है सारे।
आपको कोई बात नहीं
चलो चेक योर
मैडम आप राइट हैंड निकाल दो बस। आप होस्ट ही है।
मैंने अपना थोड़ा ना निकालना है। राइट हैंड से निकालना है। पता नहीं डॉक्टर शर्वरी गुप्ता। डॉक्टर शर्वरी गुप्ता ने 2 डाले। देवांशी जोशी। डॉक्टर रविशंकर। ओह वाह। ये लकी ड्रॉ है। लकी ड्रॉ है। तो दे दे।
कौन से एरिया
आप मेंबर हो
Now this is a mega lucky draw. Dr. Rashmi Grover. Wow. ये हार्ड वर्क का बड़ा अच्छा नतीजा है। अब नाम याद रखना। और निकालो
अब बन जा तभी मिलेगा। तभी मिलेगा जब।
Dr. Samarjit. Wow. Where is he? He did all the hard work of getting the gifts.
He's writing a check outside.
Mega lucky draw. मेगा हो गए। ओके अब लकी ड्रॉ का। अब ले वो लकी टिक के निकाल।
देते हैं क्या जब आपको